So today we are going to continue with the neoplasm of the lungs. So we'll start by talking about the pulmonary nodules, the solitary pulmonary nodules. So sometimes, incidentally, solitary pulmonary nodules might be detected. Sorry, please just a minute. So solitary pulmonary nodules might be incidental findings on chest X-ray, and then it's very, very important we evaluate that solitary pulmonary nodule because it could be malignant, and at the same time it could be benign. So, but you need to be sure, to avoid overlooking a malignant condition. So, most of the time they are asymptomatic; you don't even know it's there. But sometimes they might be symptomatic, in which you notice the person presenting with history of chronic cough, difficulty in breathing, they can have chest pain, shortness of breath. And when you discover this solitary pulmonary nodule on your chest X-ray, you want to ask for risk factors that can actually increase the likelihood of that nodule being malignant. For example, you want to take history of if the person is smoking. So if the person is smoking, it raises a very high suspicion for malignancy, or the person has history of exposure to smoke, like passive smoking, exposure to dust, like people working in all these construction companies. Asbestosis, for example, might increase the chance of that nodule being a malignant nodule. Or people getting exposed to other metals like chromium, nickel, even radiation, radioactive elements like radon, or travel to some parts of the United States. For example, people traveling to southern western United States, that nodule might actually come from infectious agents like coccidioidomycosis, or people that travels or that lives in Ohio River Valley, people that live in Mississippi. It could be, histoplasmosis or blastomycosis. So what you are trying to do with your history is just rule out the particular cause. So if the person has a very high packet of smoking, it's likely to be a malignant nodule. Or the person has history to some certain radioactive elements, some certain dust like asbestosis, metals, chromium, and the likes. All of them are supportive of malignancy. Sometimes it could be infectious. Maybe the person had, travel, or the person lives in areas where you have some fungal infections, dominating, like Ohio and Mississippi, or even some western aspect of US like California. So you want to think about things like coccidioidomycosis, which we are going to talk about more, as well as histoplasmosis and blastomycosis. Also, people that live in endemic areas for tuberculosis, like people that live in sub-Saharan Africa, people that live in Southeast Asia, Indonesia, Philippines, um, uh, um, what's other countries here? Cambodia, all those places. We can. I think I have a list of some of those countries. You want to think of tuberculosis as a cause of that nodule. So it could be an infectious granuloma, either from fungal infection or tuberculosis, or a malignancy. So what do you do? The first thing, when you do your chest X-ray and you see that nodule, you want to evaluate that nodule. So what are the features you discover in that nodule? If you see presence of, let's start with calcification. If you see, central, uniform, or popcorn calcification. So popcorn calcification just means mix of calcium and fat deposits. you want to think of hematomas or benign lesions generally. Hematomas in the lungs, or just benign lesions. So in that, once you see that feature, what you just do is just to do serial CT monitoring. You don't do any other investigation. So once you see any um, radiological feature that supports a benign lesion, like pulmonary hematoma, which includes presence of a popcorn or central calcification. Popcorn calcification, which is a mix of calcium and fat deposits, you want to consider benign uh, nodule. And of course, the person is not going to have all this history of smoking and the like. It's not going to be very, very significant. So once you have that, that is likely to be a benign nodule. You can just do serial CT monitoring for like 2 years, then you stop. That is all. But if you see any feature that raises suspicion of malignancy, like the diameter, which we are going to talk about, the age, the smoking history, or the nodal characteristics, maybe the borders are scalloped, or you see some spiky projections from the border of that nodule, then you want to move forward in your investigation. So what you want to do next is that you want to obtain a previous imaging that the person have done. So if the person has done a CT or a chest X-ray previously, you want to request for that image. So let me just show us so that um it's going to be well organized for us. So most of the time, the best initial test is a CT scan of the chest, because most of the time you detect it incidentally by doing a chest X-ray. So if you have seen the chest X-ray and you are seeing features of benign lesions, you can just do serial CT chest imaging. And once 2 years pass, you don't notice any change in that lesion, you stop. But if the features you are seeing on CT is in keeping with malignancy or high risk for malignancy or medium or intermediate risk, you want to do a chest CT scan. So just like we have here, the physician should obtain a non-contrast CT scan of the chest if a nodule was discovered on another modality, for example, chest X-ray. So if a nodule has fat or calcification, which is characterized of a benign lesion like an hematoma or granuloma, no further evaluation is required. No further. You don't need to do PET scan. You don't need to do biopsy or anything. So if it's benign, you want to do serial CT scan. Serial CT scan. Once it's 2 years, you don't notice any progression, any change, you stop. But if a nodule does not have characteristics of a benign lesion, the next step is to review the medical record for a previous CT scan if available. So you want to get, if the person has done a previous CT scan, you want to get it. So you now compare what you have previously to what you have now. Is it that the lesion you are looking at now was actually there in the previous CT and it has not changed in size? You can say that, okay, this is actually more like, you know, um, a quiet nodule, or a nodule that has a very low risk of being malignant, or a benign lesion. You don't do anything. So if you notice that you are looking at the new image and the old image that the person has done, and you notice that there's no change in the size of that nodule for at least 2 to 3 years in between, like, okay, if the person has done the X-ray, the CT scan, let's say 2 or 3 years ago, and you just incidentally detected that nodule today. So that previous CT scan that you are seeing, it's 2 years or 3 years, and you notice that the size is still constant, it has not changed. So it's likely to be a benign lesion. So you don't do anything. But if you notice that that X-ray or the chest CT that you have, the size is bigger than the one you have requested for, the previous one that you have requested, you know that there's likely to be a progression. Or when you requested for the image, you did not see any nodule. So you know that that nodule you are looking at is a new nodule. So you have to progress in your investigation by requesting for, you know, a CT scan. So you have to progress your investigation by requesting for your CT scan. So what you are now looking for in your CT scan is all of this. So you want to combine all of this to now ascertain the risk of malignancy in that individual. So these are the variables. You want to look at the diameter. How big is that nodule? So you have two extremes, more than 20 millimeter, less than 8 millimeter. So if that nodule is more than 20, that's in keeping with high risk for malignancy. If the nodule is less than 8 millimeter, that's in keeping with low. If it's between 8 to 20, that is intermediate. You look at the age, two extremity, 45 and 60 years. Is it more than 60 years? High. Is it less than 45? Low. Is it in between that? Intermediate. Smoking. The person has never smoked. That's low risk. The person has smoked. Intermediate and high. Since how many years has the person stopped? So the person stopped 15 years ago. That's low. The person stopped more than 15 years ago. That's low. The person stopped between 5 to 15 years ago. That is intermediate. The person stopped less than 5 years ago. That is high risk. Look at the nodal characteristics. Is it smooth looking? Is it low risk? Is it scalloped? Is it some irregularities in the border? Intermediate. They have some projections like spiky projections, speculations within the nodule. That is high risk. So most of the time in the question stem, you are going to easily identify the diameter, the age, the smoking history, and the nodal characteristic. They are going to give you that. So with that, you can quickly calculate the risk if it's in low, if it's intermediate, or if it's high. So by the time you are saying speculations, smoke history, more than 65 years, the person has a very high risk for, malignancy. So, and also for the classification, of course, we have talked about the popcorn classification is in keeping with the benign. For people with high risk for malignancy, they might not have classification, or even if they are going to have it, it's going to be regular. It's not going to be uniform like you have in benign lesions. So you incidentally detect. So let's start again. You incidentally detect a nodule on your X-ray, and you looked at the feature, the classification looking at popcorn. You can say that this is benign. So what you just do is that you just do serial CT scan. That is all. If it is not showing symptoms or features of benign lesion, and it's giving vibes of malignancy, intermediate or high, so you want to ask for previous imaging. So two things you want to look at in the imaging first. Do you have any nodule there or not? So if you don't have any nodule there, you know that nodule you are looking at in that chest X-ray is a new nodule. So immediately you want to request for a CT scan. If you have a nodule in that previous X-ray you have requested for, or the previous CT that you have requested for, you look at the size to what you have now. Is it that the size have increased now? So if it has increased now, that means it's getting progressive, suspicious for malignancy. You want to order a CT scan. But if it's stable, it is benign, you don't do anything. You can reassure the patient. That is, you don't need to do any further investigation. So, so when you now request, when you have a suspicion for malignancy, either low, intermediate, or high, you want to request for your CT scan to further characterize that lesion. Because the CT scan is going to give you a better overview than the chest X-ray. So you want to stratify it. Is it low? Is it intermediate? Is it high? Once you do all your stratification and everything you got is high, falling under eye, immediately you want to do your surgical resection. That's what you want to do next. You want to do your surgical resection. If you are falling category of low to intermediate, the next thing is to further stratify based on the size of the nodule. What I'm getting is low and intermediate. Maybe, for example, let me give us an example. You notice that the person is not smoking, has never smoked. The person is like 30 years, and the person is having the nodule with smooth border. That is 3 over 1, 2, 3, 4, 5, 6. Okay. 3, it's having more of, the low category. Yeah. Or the person is having the person has a smoking history. The person is like 48, and the diameter of that nodule is like 10. That falls into category of intermediate. Let's say even the other one, let's say the border is now smooth, but you have more of intermediate feature, so you put it under the intermediate. So that's how you stratify. So the one that has most feature, that's the category you are going to put it. So so once you have between low to intermediate, the next thing to do is to look at the size. Is it more than or equal to 8, or is it less than or equal to 4? If the nodule size is more than or equal to 8, you are having a very high suspicion for malignancy. So you want to order a PET scan, or you want to do a biopsy. You can do a PET biopsy, or you can do a PET scan. So if PET scan is available, it's good. So you do your PET scan and you look at that nodule clearly. So if it has some supportive feature for malignancy, you go on with your surgical resection. If you do your biopsy and you are seeing features of malignancy, you go ahead with your surgical resection. But if your PET scan or your biopsy suggests otherwise and doesn't raise suspicion for malignancy, you do your CT scan serially. So we don't really need to know the algorithm of how much, but just know that most of the time, if you are not finding any changes within 2 years, you stop your serial CT scan. Most of the time, once it's 2 years and you are not seeing any progression in changes, you stop it. So that's for 8 millimeter or exactly 8 millimeter beyond or exactly 8 millimeter. That's what you do. But if it's less than or equal to 4 millimeter, so you want to look at the risk of malignancy from all those things that you have calculated. So if it's falling within low category, maybe the person is non-smoker, the nodule is smooth, uh, or the person is less than 45, that's in keeping with low risk. So you just stop your evaluation. You don't do anything again. But if the person is falling within category of intermediate and the size is, within this range, less than 4 equal to 4, you do your serial CT scan. But if from the starting you are having diameter of 5 to 7, you go ahead with your serial CT scan. So the algorithm is a little bit, confusing, but most of the time they will not really put it this tricky. You'll be able to easily separate. Either they put you to the situation of a benign lesion, or they put you to situation of high risk for malignancy. Most of the time, they will not really put you in the situation that you have to be, doing the algorithm of PET scan, biopsy, and the likes. So once you see that, okay, it's falling within the range of high risk for malignancy, you go ahead with your surgical resection. If it's you are seeing your popcorn classification, no history of smoking, smooth murder, benign features, just do your serial CT and reassure the patient. That is it. So that is that about the nodule. Just know that once the size of that nodule is stable for more than 2 years, it's unlikely to be a malignant nodule. So it's more likely to be a benign nodule. So do we have any question on that? Do we have any question? Okay. So lung cancer. So lung cancer is the leading cause of cancer death in the
Okay, I
United
have
States.
a question.
Okay, I'm listening. Hello, I'm listening.
Hello?
Yes, I'm listening to you.
Okay, thank you. Like the algorithm. I wasn't sure. Like this size is given 5 to 7, less than 4, but on the table, the diameter of the nodule, you have 8 to 20, or is it a different? It's still millimeter mercury. So why
Uh
is intermediate 5 to 7 on the
no.
chart,
It's
and then
different.
8 to 20?
Is different. You see,
Okay,
this one that you have here is what you are going to use to stratify it first into low, intermediate, or high. Do you get it, Doc? Like,
okay, the table first before the
yes,
chart.
this is the one that you are going to do first. So let's say that maybe you got intermediate from maybe most of them fell within the category of, you know, that you might not have everything falling into intermediate. Let's say that this person is, um, when you measure the node, the node is like 10 millimeter. So 10 millimeter is here. The age of the person is 45. Is still here. The person has smoking history. That's is here. Okay. The person has smoking history, but the person stopped 15 years ago. So that is in supportive of low. And you check the characteristics of the nodule, it is, let's say, it is scalloped. So that's like 4 for intermediate. And there is no classification. So, you know, majority, you're having 14s in intermediate section. So you know that, okay, you are going to put this person into intermediate category. Then you come down. The person is intermediate, but, and the person is going to fall here, right? Because you cannot do surgical resection because it's not falling under high. The person is falling under intermediate. So we now look at the size. The size we got was 10, right? So it's not going to be here. It's not going to be here, but it's going to be here. Do you get it, Doc?
Okay, yes,
So
yes.
so 10, you do your PET or your biopsy. So if you do your biopsy and you are seeing features of malignancy, you go ahead with your surgical resection. If you are not seeing any feature suggestive of malignancy, but because the person has already fallen into category of intermediate, you want to do your serial CT scan. So do you understand it? So this level is actually different from this. This is your starting. This one is what you are going to calculate first, you know, before you now progress downwards. So, is that clear? Do you get that now?
Yes, it's clear. And then wanted to confirm is
Okay.
it just one, if one positive, for instance, if you calculate and it's all low from
Okay.
the table, you
Yeah.
still subject it to the algorithm, the chart.
So if it's all no, let me try to understand what you are saying. Let's say that you are saying maybe diameter is less than 8, age is less than 45, right? Is that what you are saying?
Yes, that's all low risk.
Okay, all low
But
risk.
maybe because of the size, I don't know. Maybe you still go through this other one, right?
Yeah, so if it's low risk, but the person doesn't have any feature of benign, you know that once you see all your the fat calcium deposit and the popcorn calcification, you know that it's benign. So you want to put that as benign lesion. Then you do your serious CT scan, you stop. But let's say that the person has, let's say, maybe no calcification. No calcification. The person has smooth nodule. The person has stopped smoking, or the person has not even smoked before. The person has not smoked before. Smooth nodule, 40 years, diameter less than 8, but the person has absent of calcification. So you know that that's a low risk individual. So you come here, the person is going to fall in this category. You now look at, okay, this person is low risk, but what's the diameter? Okay, the diameter is it 6 or the diameter is 3? What you are going to do if it's 3 is different from if it's 6. So if it's 6, you are going to do serial CT scan. If it's 3, you are going to come here again and look at it holistically. But from what we have said, that person will not fall into intermediate because the person has more feature of low. So we are just going to stop evaluating that patient.
Okay, it's clear now. Thank you.
So uh lung cancer. So lung cancer is the commonest cause of death in the US. So the most common risk factor for lung cancer is tobacco smoke, except a particular histologic feature or a particular histologic type rather of lung cancer, and that is a bronchial alveolar carcinoma. So you have to watch out for that. Bronchoalveolar carcinoma is a form of adenocarcinoma of the lung. So smoking is not a strong risk factor for that. While the other one is radon. Please don't forget. If you don't see smoking in the option, please look for radon exposure, and of course asbestosis. Asbestos exposure is a very common cause of lung cancer, even more than mesothelioma. Please don't fall for the trap. Don't fall for the trap. Asbestosis causes bronchogenic carcinoma more than mesothelioma. So these three things: tobacco smoke exposure, both active and passive, radon, and asbestos. So what are the types? We want to separate them into two categories: the small cell and the non-small cell. The small cell and the non-small cell. So the small cell is also known as a old cell. I can say that this is the most aggressive form of lung cancer. So we don't want any of our patients to have this because they are going to be definitely problematic. Number one, you tend to find it in the central aspect of the lung. So they are very close to the central aspect of the lung. That's the first thing. And it is very, very commonly associated with smoking. Small cell carcinoma is highly metastatic, and most of the time you pick it at the late stage. It is high grade, meaning it is undifferentiated. So the small cell carcinoma doesn't look like the tissue or the cells where it's from. And where is it from? Where is it derived from? It is derived from the Korchinski cells of the lung. So the Korchinski cells of the lungs are just neuroendocrine cells that you find lining the tracheobronchial epithelium. So they are just there to maintain the integrity of the epithelium, to ensure the functionality of the vessels and some other minor function like hormone and transmitter production that they do. So they can secrete some things, serotonin and the likes. So these Korchinski cells appear as small dark blue cells. So once you see this on histology, you know that they are definitely talking about a neuroendocrine tumor. And the one for the lung is the one derived from the Korchinski cells. They appear small, round, dark blue cells. So don't forget, small cell carcinoma is central in location. It is highly associated with cigarette smoking. It is high grade or undifferentiated and very, very aggressive, so that it spread rapidly. And most of the time, you catch it at the later stage where it has progressed massively. And where does it commonly metastasize to? BLB, the brain, the liver, and the bone. BLB, the brain, the liver, and the bone. Those are the common site of metastasis for small cell carcinoma. And we must also remember the paraneoplastic features of small cell carcinoma. When we say paraneoplastic, we mean the features of small cell carcinoma that is not explained by metastasis or by local compression or local involvement of these tumors. Most of them are explained by cytokine release. That is it. So, we have to remember the A's. That's the way I learned it. The A's for small cell carcinoma. The two A's commonly tested: ACTH and ADH. Secretion of ACTH causing Cushing syndrome, and ADH causing syndrome of inappropriate secretion of ADH. You know that when you have increased elaboration of ACTH, the person is going to have Cushing syndrome, which I know Dr. Babinda have taught us, so we don't need to talk about the features. We know how the presentation is going to look like. They can have syndrome of inappropriate secretion of ADH. So, reabsorption of fluid and the like, production of concentrated urine because of increased secretion of this ADH. So they are going to have euvolemic hyponatremia. So that's that about. So don't forget the euvolemic hyponatremia shared with ADH. They are reabsorbing fluid, into their what's it called? their their system, you know. Sorry, 1 minute. Okay, thanks. Yeah, so they are reabsorbing fluid into their system, but because the body wants to prevent hypervolemia, so that hypervolemia doesn't happen. So they are going to trigger release of AMP, BMP, so that that one can be moving sodium out. And we remember that when sodium moves out, water will follow. So at the end of the day, they are not going to be hypervolemic. They are going to be euvolemic, and at the expense of loss of sodium. So the person is going to be hyponatremic at the end of the day. So that happens in syndrome of inappropriate secretion of ADH. Hypo, um, sorry, euvolemic hyponatremia. Euvolemic hyponatremia. Don't forget. So, um, antibodies, they can also increase production of antibodies against presynaptic calcium channels, causing Lambert-Eaton Myasthenic syndrome. So, another paraneoplastic manifestation of small cell cancer, aside the two ways, for ACTH and SIDH, is antibodies. That's another A against presynaptic calcium, causing Lambert-Eaton syndrome. So we know how the person is going to present: the proximal myopathy, diplopia, ptosis, weakness of proximal muscles, and of course the autonomic symptoms, incontinence, orthostatic hypotension, and all those things. Once you see autonomic symptoms with proximal myopathy, ptosis, and all those things, you want to consider Lambert eating. Very, very important. So, and if you get that, you have to rule out small cell carcinoma in that person. So if it's just myasthenia gravis now, you want to consider a thymoma. Then the last one is neuron manifestation. So once you see any neuron, any CNS that share paraneoplastic manifestation, you have to consider small cell carcinoma. That is it. Peripheral neuropathy, paraneoplastic myelitis, paraneoplastic encephalitis, any neuronal involvement, it is likely to come from small cell carcinoma. That's the way to learn it. So see them having paraneoplastic myelitis, they are complaining of weakness, flaccid, paralysis of the lower limbs, paraplegia. They can have bladder bowel issues, sensory loss, and of course for the encephalitis, affectation of the brain. So they can have personality problems. Most of the time, the earliest symptoms of the paraneoplastic encephalitis is psychosis. So they can have hallucinations, personality changes, then cognitive problems start setting in, poor memory, poor judgment, then seizures. So that's for the paraneoplastic encephalitis. Um, for the histology, we have talked about the fact that you are going to see the small um, dark blue cells, which is suggestive of the fact that it is a neuroendocrine tumor derived from the Kochiski cells. And you want to also furthermore delineate it by doing your immunohistochemistry, in which you are going to stain for um, three things: your chromogranin A plus, your neuron-specific enolase, and synaptophysin. So there's no place to write this thing here because of the fact that this thing. Okay, let me see. Neuron-specific enolase, neuron-specific enolase, uh, and synaptophysin. So the three of them are present in an individual with small cell carcinoma. So because of the fact that small cell carcinoma, most of the time it is metastatic. It's already advanced by the time you are making your diagnosis. So you can't really do much, but you can try by placing the person on chemotherapy. So you place the person on chemotherapy. That's what you do most of the time. But if you catch it at a very early stage and the person is lucky, you can consider surgery. And of course, before you do your surgery, you might want to administer your neoadjuvant chemotherapy to help you debulk that tumor. And what you typically do in the early stage is that you know that you are doing surgery. So you do your neoadjuvant chemotherapy with radiotherapy, then you go in and try to remove it by doing a lobectomy. Most of the time, that's what they do. But once you notice that, okay, this is an advanced form, you just do your chemotherapy. That's all. So you dare not operate that tumor. So for adenocarcinoma, adenocarcinoma is peripheral, unlike small cell carcinoma that is central. So adenocarcinoma, you find it within the peripheral aspect of the lungs, and it is very, very common in females. So I want to mention that once you see, once you get an history of an individual that is a female that is non-smoking, and the person is having features suggestive of a lung malignancy, you have to consider adenocarcinoma. Adenocarcinoma. The drivers for adenocarcinoma are these mutations: your KRAS mutation, your EGFR mutation, and your ALK translocation. So these three ones, they are usually the oncogenic, mutations that just be driving it. So you want to administer some targeted therapy against this component. You can give EGFR inhibitor, KRAS inhibitor, or ALK, inhibitors, because you know that most of them come from either of these three conditions. So on histology, what are you going to see? Glandular pattern, because adeno means gland. Adeno means gland. So you are going to see glandular pattern, on your histology, something looking like glands, and they stain positive for mucin. Just like these ones are staining positive for neuron-specific enolase, naptophysin, and the chromogranin A, it stains positive for mucin because the glands within the lungs, they secrete mucin. So you have some subtype, and that is the bronchoalveolar subtype. It's very, very important we know this. So it's a form of adenocarcinoma in situ. That is adenocarcinoma that has not breached the basement membrane. So it has a very excellent prognosis because it is still confined within the alveoli. So adenocarcinoma typically will occur within the bronchioles and the adjacent alveoli. So it is still confined within the alveoli and it has not breached the wall. It's growing along the septa of the alveoli. So it appears thickened. You notice that alveolar wall is thickened. So once you see that kind of histologic presentation, you know that you are dealing with the bronchoalveolar subtype or the adenocarcinoma in situ subtype. So it's very, very good. That's a very good prognosis. So the paraneoplastic manifestation associated with adenocarcinoma is what? Hypertrophic osteoarthropathy, finger clubbing. You must know this. You must know this. We have some other ones which we are going to mention. For example, migrating thrombophlebitis. Migrating thrombophlebitis is very common with adenocarcinoma as well as hypertrophic osteoarthropathy. Then the next is squamous cell carcinoma. Squamous cell carcinoma is central, just like small cell. But what gives it away quickly in question? You are going to get the history or they are going to put in the question stem that there are cavitations in your imaging. Once you see cavitations, either maybe when you do your biopsy or you do your imaging or anything, you are seeing cavities. That is talking about squamous cell carcinoma because it's highly, rapidly dividing. The tumor cells outgrow their blood supply and they eventually become necrotic. So at the end of the day, you see them forming cavities within the lungs. So once you see cavities, the person is smoking, central distribution, you want to consider squamous cell carcinoma. So when you do your histology, when you do your biopsy, you notice concentric growth or concentric proliferation of the epithelial lining, secreting keratin. So the epithelial cells are going in a concentric version or format, releasing keratin, and they are kind of interconnected by desmosomes you call intercellular bridges. So once you see keratin pairs with intracellular bridges connection, what you are dealing with is squamous cell carcinoma. So don't forget cavitation. So somebody asks you, can you tell me about squamous cell carcinoma? If you have not mentioned this, we have not said anything. You must talk about the fact that it's associated with cavitations and histology. You are going to see keratin pairs and intracellular bridge. That's just what you are looking out for. And to now nail your diagnosis, or they can ask you in your exam, like, what is going to be the paraneoplastic manifestation for squamous cell? We know that for small cell, we are watching out for ACTH, we are watching out for ADH, we are watching out for Lambert-Eaton, we are watching out for paraneoplastic encephalitis and myelitis. Here is only one thing, hypercalcemia from parathyroid hormone releasing peptide secretion. Many people forget. They forget and they go and pick PTH. We are not picking PTH. It is PTH related peptide that is doing the work. It is PTH releasing peptide that is activating the osteoclast, causing bone resorption, leading to the hypercalcemia. Don't forget, just like small cell, it is highly associated with smoking and it forms cavitations. Large cell carcinoma is another one. So large cell carcinoma, just like adeno, is peripheral. So that's why it's kind of mimics some non-small cell cancer in a way. But it also mimics small cell because it is highly undifferentiated. It has a high grade, meaning it is undifferentiated. So, and it is peripheral in distribution. So it has a bad prognosis. Um, and but it's kind of amenable to surgery. You can try to do surgical removal. The reason why it has poor prognosis is because it's not highly responsive to chemotherapy. So most of the time you try to attempt surgical debulking. And when you do your histology, you are going to see pleomorphic giant cells. So it's very straightforward. You do your histology, you are seeing pleomorphic giant cells. That is large cell adeno, large cell carcinoma belongs, large cell carcinoma. Then the last one that you are going to encounter a lot by the time we start looking out for question is the bronchial carcinoid tumor. The bronchial carcinoid tumor. Now, I know that most of us we have it at the back of our mind that what we have to look out for bronchial carcinoid tumor is evidence of carcinoid syndrome, like release of the histamine and the serotonin causing the flushing, the pruritus, the diarrhea, the wheezing. But no, most of the time this carcinoid tumor present with feature of bronchial obstruction. So it grows from the bronchus just like the other ones. It grows from the bronchus, but it kind of occludes that bronchus. So leading to obstruction of the airway. So you see the person present with cough, difficulty in breathing, wheezing, cough, difficulty in breathing. And because of the fact that mucus tends to accumulate distal to that obstruction, the person is going to be having recurrent pneumonia. So this is a very good candidate, for bronchiectasis because of that obstruction. So you see, having recurrent infection leading to eventual dilatation of the airway and bronchiectasis. So, but in some instances, you can see their carcinoid manifestation, in which the neuroendocrine cells, where they are derived from, they start releasing serotonin, histamine, and the other hormones, leading to the features of carcinoid presentation, like flushing, like the pruritus, like the diarrhea, like the wheezing. But carcinoid syndrome from Midgard problem is more shared with those features rather than bronchial carcinoid tumor. So if you have a carcinoid tumor that's coming from the midgut, they tend to have more of that flushing, diarrhea, wheezing presentation than the bronchial carcinoid tumor. So I want us to have that at the back of our mind. And on histology, we are going to see the neuroendocrine cells, the small round blue cells, just like in small cell carcinoma, and they are going to be arranged in nest or trabecular meshwork separated by a fibrovascular septate. So don't forget, this tumor, before I go, is highly vascular and it's usually confined within the bronchus. So by the time you do your CT scan, you are going to notice that vascular enhancement, and you are going to notice that this person is going to be presented with obstructive symptoms, cough, difficulty breathing, recurrent pneumonia, and most important thing that I almost forgot to mention is that they are very common in young adolescents that are not smoking. So You see a young adolescent, 20 years, 15 years, or like 25, that's having obstructive symptoms, and you are thinking of a malignancy, and the person have not smoked, go for bronchial carcinoid tumor. Go for bronchial carcinoid tumor. So we can see X-ray here showing a central tumor, though this for small cell carcinoma, but we might not be able to say if it's small cell or, but because maybe we are not seeing much cavities or the like, so we can say that this is small cell because it's central in position. So so that's that about the chest malignancy. So how do they present? So they can cause cough, typically cause cough, hemoptysis, difficulty in breathing, wheezing when there is obstruction of the airway. They can cause recurrent pneumonia, just like I've said, particularly in bronchial carcinoma due to obstruction of the airway, mucus accumulation downstream, providing a fertile site for the bacteria to be proliferating and eventual infection. It can cause chest pain, either from compression or from inflammation. Of course, weight loss at the end of the day is a chronic inflammatory process. The person is going to definitely have weight loss. And depending on the additional complications, if there's pneumonia, they can have crackles. Of course, if there's obstruction of the airway, they can have obstructive atelectasis. So I've explained this when we were talking about the types of atelectasis. We said atelectasis can occur when there's obstruction of the airway. Air cannot move downwards again. So the air that is remaining in that down part can be absorbed. And when it is absorbed, the airway collapses. So it's also important to talk about the superior sulcus tumor, which is also known as the Pancoast tumor. So these are tumors that arise within the apex of the lung. Most of Pancoast tumor are non-small cell tumors. They are of the non-small cell type. Most of them. So they are located very close to some structures like nerves, like vessels. So, for example, nerves, the brachial plexus. So they are very close to the brachial plexus. You can have easy compression of the brachial plexus, particularly the lower trunks of the brachial plexus, the C8 T1 component. And we know that this is the region where the ulnar nerve comes from. So once you notice that they are going to have weakness, paralysis of the intrinsic muscles of the hand. There's going to be weakness, paralysis of the intrinsic muscles of the hand. And in addition to that, the commonest presentation, which is shoulder pain and arm pain. So that is that. So T2 is very, very close to the shoulder, so they can have shoulder pain and also referred pain to the arm. So don't forget, the initial symptom they usually have due to brachial plexus compression is shoulder pain, which can refer to the arm, and eventually paralysis and weakness of the intrinsic muscles of the hand. We remember that ulnar nerve supplies all the intrinsic muscles of the hand except loaf. Yeah, the lateral lumbricals, the opponent's pollicis, the abductor pollicis brevis, and the flexor pollicis brevis, which are all supplied by the median nerve. So ulnar nerve supplies all the intrinsic muscles of the hand except loaf. So they can also compress on the paravertebral sympathetic chain and inferior cervical ganglion. So by the time Dr. Babani start telling us about, I think okay, we are already familiar with all these the sympathetic nerves, so we know. So just to show us the superior, the stellate ganglion, lung cancer. So it's very, very close to that area, and it can get compressed. So just like okay, so this is the stellate ganglion here. So it's the fusion of the C8 ganglion with the first thoracic ganglion. So they fuse together at this point, and any tumor that arises from this region can easily compress on it. and the person is going to be having affectation of the sympathetic nerve, which are ascending to the face. We know that they come down from the hypothalamus, they pass through the ciliospinal center before they now, join with the stellate ganglion, then move up, to the face. So at that portion, they can be compressed, and the person is going to be having features of Horner syndrome, which is PAM, 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 ptosis, anhidrosis, meiosis. So PAM, PAM, uh, ptosis, meiosis, and anhidrosis. So the person is not going to be sweating. There's drooping of the eyelids, and there's constriction of the pupils. So that's in keeping with Horner syndrome. Still on nerves, there can be affectation of the recurrent laryngeal nerve. It's very close to that area too, and the person is going to present with hoarseness of voice. Hoarseness of voice. It can also affect the phrenic nerve. It's not here, but it can affect the phrenic nerve too, as it moves down to supply the diaphragm. So because it emerges from the cervical spine, C3, C4, C5. So you can have compression of the phrenic nerve, and you are going to notice ipsilateral diaphragmatic paralysis and elevation of that segment of the diaphragm on the chest X-ray. So that's that about the nerves, your brachial plexus, your sympathetic trunk, recurrent laryngeal nerve, and of course the phrenic nerve. For the vessels, superior cervical, superior vena cava syndrome, superior vena cava syndrome, superior vena cava syndrome. So the upper lobe is very close to the superior vena cava where it enters into the heart. So anybody that has compression of the SVC will have some certain presentation, including supraclavicular venous engorgement and facial swelling. We know that the SVC is formed by joining of two major vessels. Who remembers the two major vessels that form SVC? Anybody wants to remind us? Anybody wants to remind us the two vessels that form the SVC?
Is it common carotid artery?
No, no.
Is brachiocephalic vein and then another vein.
Okay. Oh, SVC. Okay. Yeah.
SVC,
Vein.
SVC,
Vein. Vein. Yeah. I
SVC.
said artery. Sorry.
So
Yeah.
how it is formed is that you have joining on the right and the left brachiocephalic vein.
Brachiocephalic. Yeah.
The,
Sorry.
the right and the right will collect it from the right. The left will collect everything from the left. It will now join together. They will now tilt towards the right to form the SVC, which will now enter the right atrium. But the brachiocephalic too are formed by two things. The subclavian vein that is draining the arm and the upper trunk, as well as the IJV that's draining structure from the head. So it means that if there's obstruction of this SVC, there's going to be congestion upstream. And upstream the SVC, we have our right and left brachiocephalic. So it means that up the right brachiocephalic, we are going to be having blood pulling up in the IJV, internal jugular, blood pulling up in the subclavian vein. So there's going to be upper limb congestion. So there's congestion of the arm because of the SVC, and there's going to be congestion of the neck and the head because of the IJV. So the person is going to be having facial swelling. You are going to notice elevation of the internal jugular, pulse. Like you see the pulsation increasing and congestion everywhere around it because of obstruction of the SVC. So it's going to be bilateral. So that should raise your suspicion for SVC syndrome. But if you notice that it is unilateral, it's only one segment, then you want to think about brachiocephalic vein compression. So that is very important we note it. So looking at the paraneoplastic syndromes again, the summary. So we have talked about the endocrine one. We know ACTH, SIDH from small cell carcinoma. We know the parathyroid hormone-related protein from squamous cell. Then gynecomastial comes from large cell. Large cell can elaborate HCG. HCG can stimulate, it works like luteinizing hormone, can stimulate the release of androgens, right? So androgens from the Leydig cells secreting testosterone. The testosterone can easily undergo aromatization to the estrogen, and those guys will go easily to the breast, and they start stimulating the breast tissue to become big and big and big. So it's very common in males, gynecomastia, large cell carcinoma, gynecomastia. For the skeletal, hypertrophic pulmonary.
Sorry, sorry, Doctor, sorry to cut you in. You said the gynecomastia is from what?
So
From the last
the latter is going to be elaborating HCG,
SGG.
human
Okay.
chorionic gonadotropin. So HCG
Okay.
and LH, you know they are like similar. Okay, we have not done 1G. So
Yeah, no, not yeah, but I
yeah,
think they share the same alpha unit or something.
yeah. So they can actually act on like similar receptors, alpha unit. Very nice.
Okay.
So
And again, you said the superior sulcus tumors, you say, are they mainly of small cell or non-small cell?
non-small cell,
Non-small.
yes.
Mm.
So hypertrophic pulmonary osteoarthropathy is just finger clubbing. That's just it. There's clubbing of the fingers. There's arthritis. Those fingers are going to be painful, and you notice some periosteal reaction. So in summary, finger clubbing, that is hypertrophic osteoarthropathy. So most of the time, it's going to come from which tumor? They said non-small cell, but which one particularly? Anybody remembers?
Adenocarcinoma.
Adenocarcinoma, fantastic. So this is neuromuscular. So peripheral neuropathy, subacute cerebellar degeneration, myasthenia, dermatomyositis. You want to think of small cell carcinoma. Although dermatomyositis can come from all. Most of the time, dermatomyositis you think about ovarian, but it can also come from all of the what's it called? All of the lung cancer. But anything specifically neuro, like myasthenia, cerebellar degeneration, paraneoplastic myelitis, paraneoplastic encephalitis, peripheral neuropathy, think about small cell. Think about small cell. Migrating thrombophlebitis. So you notice redness, swelling, pain in the leg, and it's moving from the leg, is going to the arm. You are seeing that movement from one place to another place. You are thinking of an adenocarcinoma. The commonest cause of that presentation is pancreatic adenocarcinoma, but it's not unusual too with lung adenocarcinoma. So they can also cause the marantic endocarditis, which is non-bacterial verrucous endocarditis, meaning endocardial vegetations that are sterile. It's just containing fibrin aggregate and a platelet. That is it. Nothing, not like no infectious agent is located there. So they have a very high risk of embolizing. That is a risk. So you need to anticoagulate. If you catch any patient with verrucous endocarditis, which is sterile, you have to anticoagulate that patient because they have a very high risk of throwing that clot, into the circulation. So it's very common with adenocarcinoma. Very, very common with adenocarcinoma, pancreatic adenocarcinoma, lung adenocarcinoma. Also SLE. Dr. Brian is going to teach us when we get to the cardiovascular section. So hematologic, these malignancies too can release some cytokines that can destabilize the hematologic system. So they can cause anemia. Of course, we know most of the chronic infection, it is anemia, that anemia of chronic disease and the like. So they can cause elaboration of more platelets, thrombocytosis, and we know thrombocytosis can cause DIC. Just have platelet everywhere. At the end of the day, trigger coagulation, leading to hypercoagulability. And when there's excessive coagulation, you are going to consume all of them, and at the end of the day, it can lead to DIC. So anemia, thrombocytosis, hypercoagulability, DIC. So that's why malignancy is one of those high risk factor for hypercoagulability. It is one of those high risk factor for pulmonary embolism. So that's why we gave it 0.1. With our, I don't know if you remember the acronym. Anybody remembers the acronym that we are using?
DPICT.
Yes, DPIT Headmaster HM. So DPIT Headmaster. So the DVT,
Malignancy.
features of DVT, is it diagnosis in keeping with pulmonary embolism? That's a P. The next P is any previous history of DVT of E or DVT or pulmonary embolism. The I is immobility, surgery within like a month or immobility for 3 days. The T is tachycardia greater than 100, and the H is for hemoptysis, and M for malignancy. So the last is the cutaneous acanthosis nigricans. So although you typically see these are just like valvety lesions, hyperpigmented valvety lesions that you see within the intratiginous area of the body, like the groin, the armpit. Very common with people with obesity for the non-malignant one, and people with gastric adenocarcinoma, like GI cancer for the malignant one. So you can also see it in people with lung cancer. So the best initial test to do is to order a chest X-ray or the CT scan of the chest. So so if the chest X-ray or the CT scan reveals feature that is suggestive of a malignancy, so you want to obtain a tissue sample, and the approach in which you are going to take to obtain that sample depends on the location of the tumor. So if it's an adenocarcinoma, for example, which is going to be more peripheral, or a large cell carcinoma, which is going to be more peripheral, you want to go through a fine needle aspiration, which is CT guided. So you do a CT imaging and you advance your needle, to take it from the peripheral, so it's more like having the chest like this, and you have a tumor that is here. So why come from here? Why not come from here and just take it, bam, and you move? So your fine needle aspiration, which is CT guided for peripheral. Why the ones that are central, that are here? Because you are going to stick the needle, bam, for too long. It's going to cause too much pain now. So go through your bronchoscopy and you do your bronchoscopic biopsy, or you take brushings for central lesions. So bronchoscopic brushings or biopsy for central lesions. Why for the peripheral? You just do your fine needle aspiration with your CT guided imaging. So once you make your diagnosis, so you can use that CT that you have taken to also stage it, or you can do a PET scan. So that's all about the management. So you want to obtain your initial imaging with your CT or your chest X-ray. So anyone, if you suspect that this is suspicion for malignancy, you want to do your biopsy next. Depending on the position, that will guide the approach for making your biopsy. Then you stage with your PET scan or your CT scan. So the treatment typically depends on the stage. So early stage, just like we have said, may require surgery, with or without neoadjuvant, depending on how big it is. So if it's very big, you might want to do a neoadjuvant stuff, chemotherapy to debulk it, to reduce it before now going into your surgery. Sometimes you can try to remove and you now give chemotherapy afterwards. So that's going to be adjuvant to eradicate any remnant that is there. So you can, use your chemotherapy afterwards, your immunotherapy, and your radiotherapy. So that is that about the treatment for the lung cancer. So some of them are highly responsive to surgery, like someone that has large cell carcinoma. You should try to do surgery. Don't waste your time doing chemotherapy. Someone that has small cell carcinoma, because most of the time you find it metastasized already, so you just want to do your chemotherapy. If it's early, you can do chemo radio combined, then you try to go in and remove the tumor if it's early. So just like we've said, prior to surgery, the neoadjuvant therapy helps us to reduce the size of the tumor, right? And sometimes you can give adjuvant therapy, after surgery, to decrease the chance of residual disease, just like we have talked about. But for advanced stage disease, systemic therapy is the best. So you have to give your chemo, for example, in people with small cell, which present in the advanced stage, to treat. that condition. So very common for people with inoperable tumors like stage 3 or people that are not fit for surgery. You know, uh, so
Sorry, I wanted to ask, is there a difference between neo and adjuvant therapy?
yes, I've explained. So neoadjuvant means that you are giving the chemotherapy before surgery. So you give it before surgery, you reduce the size. That's what you are trying to do. Then you now go in and operate. But for adjuvant, you do your surgery, you now give the chemo to kill off any residual that you have not eliminated completely. So that's adjuvant. Do you get it?
Mm-hmm.
Yeah. So that's the way it works.
So
So
that means
Okay, yes. Neoadjuvant before surgery. Okay, yeah.
yes,
okay. So that means if you didn't do the neo, you can do the adjuvant. That means after the surgery, you can now follow up with chemo and radiotherapy.
exactly. So
Okay.
adjuvant can be anything. Adjuvant radiotherapy, adjuvant chemo, adjuvant immo, meaning you are giving that treatment after you have done your surgery to kill off any residual tumor that you have not removed in the surgery.
Mhm.
So any one of them.
And I have another question, Dr. Babawala. So when you're talking on the paraneoplastic syndromes, um, in the non-bacterial endocarditis, do you
Okay.
see it? Yeah. Is it only in adenocarcinoma?
Yeah, so I mentioned another thing. I said SLE. So
Yeah, I know. Yes, early. I'm talking about like tumors. Is it the only
yes,
adeno?
adenocarcinoma, most of the time, adeno. In fact, the
Okay.
commonest tumor that causes it is pancreatic adenocarcinoma.
Okay.
So it's the
But,
adenocarcinoma.
but the endocarditis, not the migratory thrombophlebitis.
Both of them. Both
Both
of
of
them
them is
is
pancreas. Okay.
adeno. Yes, both of them.
Oh, okay. And in dermatomyositis too, do you see it all of them? I think you said something.
Dermatomyositis is all of them. But I
All of
said
them.
for ovarian adenocarcinoma is more likely to be the cause of
Okay.
dermatomyositis. Ovarian carcinoma.
Okay.
Okay. So a 65-year-old patient with 30 pack year history presents with a 2 weeks history of facial swelling. CT imaging reveals a hilar mass and biopsy reveals small cell lung cancer. What is the next step in treatment? What do you want to give this patient? Anybody?
You radio.
Why?
Systemic.
It's called systemic treatment because it's by the time you find it's almost like advanced, it has metastasized. So and
Okay.
yes,
But
they
but we
done
said radios were early.
That's why I said systemic. We need to give systemic.
we give systemic.
So
No,
we have to give systemic chemotherapy.
Yeah, that
mm-hmm.
will be helpful.
So that's what we are going to do. So for the chemotherapy, you are just trying to kill off the cells, but you know it's an imprecise way. It's going to take off LD cells too. So
Mm-hmm.
we know the side effects of chemo. We don't need to waste time there. Targeted therapy is when you know the likely mutation that is driving our cancer. For example, someone that has um, adenocarcinoma, we know three things: EGFR, ALK, and the KRAS. EGFR, ALK, and the KRAS. So we can give targeted therapy that can block these specific mutations for EGFR inhibitors or ALK inhibitors. So you can treat it. That's targeted therapy. Immunotherapy just means you are just giving agents that activate, the immune system, the T cells, particularly the CD8. That's what you are doing because we know there are some checkpoints, within the immune cycle that kind of regulate the activity of the T lymphocyte. So, for example, CTLA4 kind of suppress the activity of the T lymphocyte. So, give a CTLA4 blocker, take out CTLA4 so that the T lymphocyte will be activated in an uncontrolled manner and they can take out those tumors. PDL ligand inhibitors as well as PD1 inhibitors. So you need to inhibit this guy, because when you have interaction between PD ligand on the tumor cells and PD1 on the white blood cells, on the immune cells, they kind of the tumor cells kind of suppress the immune cells with that. So PDL ligand is expressed within the tumor cells. The PD1 is expressed within the CD8 cells. So when you have PDA ligand 1 and PD1 interaction, that interaction is going to suppress the activity of the CD8 cells, and they will not be able to eliminate their cancer cells. So what do? You give either inhibitor of PDL1 or inhibitor of PD1, so that interaction will not take place, and your T cells will be in charge to eliminate the tumor cells. So that is immunotherapy. You are just trying to influence the activity within the checkpoint. So moving on to
the CTLA4, I mean, when you block it, it prevents T cell exhaustion, right?
no. CTLA4 kind of suppress the activity of your.
That's it. Suppresses T cell function.
Okay, you said exhaustion. Okay, yeah, that's
yes.
correct.
Yeah. So, but when you block it, it will not prevent that T cell exhaustion, so that T cells can function.
Yeah. So it's like a checkpoint molecule. Yeah. So pneumonia, we are going to talk about the epiglottitis, tracheobronchitis, bronchitis in the pediatric section. So here we are talking about pneumonia. So pneumonia is just infection of the lungs parenchyma caused by three major agents: the bacterial, the fungi, the viral. Okay, the answer is here. The mainstay of treatment is chemotherapy, high rate of response. Yeah. So these are the agents that can cause pneumonia: bacterial, fungal, viral. So when you are dealing with a patient that you are suspecting pneumonia, you want to obtain some certain history, living conditions, how well ventilated is that place and the likes. You want to obtain social history, particularly smoking and alcohol, because this can give you an idea of the underlying cause, the underlying infection that is causing it. Comorbidities, obesity, COPD, immunosuppression, diabetes, all those things. It can also give you an idea of the likely cause and how you can manage that patient. So history of hospitalizations. Patients that have been hospitalized for so many times, they can have pneumonia from some certain organisms like Pseudomonas. You can't forget that for your exam. Once you say hospitalization, pneumonia should come to mind. Pneumonia from Pseudomonas. From Pseudomonas should come to mind. Hospitalization. Pseudomonas. So how do they present? Acute onset of fever. Actually, it depends on the underlying cause. So for the common typical cause of pneumonia, because we have the atypical cause and the typical cause. So for the typical cause of pneumonia, they usually present with acute onset of fever, productive cough, please take note of the word productive, productive cough, acute onset of fever, difficulty in breathing, pleuritic chest pain, fever, productive cough. So the character or the nature of that cough, in terms of the character or the nature of the sputum can give you an idea of the underlying organism. For example, if you are seeing purulent yellow greenish sputum, you want to consider Pseudomonas. If you are seeing currant jelly, red currant jelly, you want to think about which organism? Anybody? Step one. Currant jelly. Huh?
Klebsiella.
Yes, Klebsiella. So if you are thinking of rusty color,
Pneumonia.
Strep pneumo.
Strep pneumo. So we can have idea of from the nature of the sputum, we can have idea of the underlying cause. So sometimes we might not get much symptom from people that are immunocompromised or people that are old, because their immune system are not able to react vigorously to the infection, and you don't have the inflammatory exudate being produced, and they might not even have cough, they might not have sputum, because all those things are product of inflammation. So if the inflammatory response is not very rigorous, you might not have all those symptoms. They will just be subtle in there. Why in some atypical setting? So before I leave, the typical ones are caused by bacterial majorly, because we have it here, bacterial, fungal, and viral. So the typical presentation that we have talked about comes from bacterial, like the number one is strep pneumo. Strep pneumo is number one. Then Kleb, we can talk about Kleb, we can talk about Haemophilus. You know, those are agents that typically cause pneumonia. Haemophilus, Staph aureus, strep pneumo, group A, even gas can cause pneumonia. Yeah, but not very common. Why the atypical one now comes from the viral and the fungal, but most of the time viral, and sometimes from some bacteria that you cannot culture, like you need special medium, like all these our chlamydia, mycoplasma, all those legionella, those ones, they can cause atypical ones. Or the viruses, respiratory syncytial virus, adenovirus, rhinovirus, influenza, parainfluenza, all those ones, they can cause the atypical cause. And what are you looking out for to separate the atypical from the typical? You look at the progression, you look at the onset. It's not acute. So it will develop over some days, gradual onset of the symptom. You look at the productiveness. Is the cough productive? If it is non-productive, dry, you know that you have ruled out the typical agents like strep pneumo, Staph aureus, Kleb. They are gone. So you start thinking about other things. Dry cough, you look out for constitutional symptoms, myalgia. You don't see this when somebody has strep pneumo or Staph aureus. You don't see myalgia, but when you are getting muscle aches, headaches, muscle ache, headache, sore throat, you think about other things. So, which we are going to look at one by one. So, for example, someone that has Legionella, they have prominent GI symptoms. They have the cough, which is dry, gradual in onset, the GI symptoms, abdominal pain, nausea, diarrhea. You are thinking of Legionella. Somebody having gradual onset, dry cough, headaches, myalgia, no rhinorrhea, no sore throat. You can think of mycoplasma. If the person is young, or if the person had history of camping, military barracks, daycare, schools, dormitories, young age, mycoplasma. If you are seeing, in addition to all this dry cough, the myalgia, sore throat, rhinorrhea, you are thinking of the viral. Is it influenza? Is it parainfluenza? Is it adeno? So that's the way it works. So what are those things we are going to look out for in our lung examination? So most of the time, the pneumonia is usually complicated by consolidation. You're having fluid pulling up in that parenchyma. So it's becoming hard. It's becoming dense. So you notice that the breath sound is going to be increased. An increased breath sound is bronchial, not vesicular, but bronchial breath sounds. Because of the inflammatory product, you are going to listen to crackles as if they are stepping on leaves. Rails. That's the rails. Crackles. Wheezing. They can have wheezing, mucus occluding the airway. They can have wheezing, but it's not a typical finding. So the typical findings are the bronchial breaths, increased breath sounds, the crackles or the rails, dullness to percussion. Consolidation is dull to percussion. Egophony. By the time you tell the patient to pronounce A, they are going to be, to pronounce E, they are going to be sounding like A. So that's like adding nasal quality to the tone. It's because of the increased density of lung tissue from the consolidation, amplifying that stuff you are pronouncing. So it's going to change from E to hey. E, A, E, A, E, A. The tone of A is higher than he. So A is higher than he. So that is a gophony. That's a gophony. You can see that typical description like that in your questions there. You know, they are trying to talk about a gophony, talking about consolidation, talking about pneumonia. If you do your tactile fremitors, anybody knows what is going to happen? Tactile fremitors, consolidation. Is it
It's,
going to increase or
it's
decrease?
increased.
It's going to be increased.
Increased.
Priority
It's going to be
only
increased.
in inflation increases, the rest
Yes.
reduces.
So, what is the next line of action? You do your chest X-ray, just like lung cancer, chest X-ray or CT. Here too, chest X-ray is the best initial test you have to do. Chest X-ray is the best initial test you have to do when you suspect pneumonia. Chest X-ray is the best initial test you do when you suspect pneumonia. So, if the chest X-ray doesn't reveal the clear infiltrate, you are not saying the lobar infiltrate, the bronchial infiltrate, the interstitial infiltrate, then you can now do your non-contrast CT scan of the chest. You do your non-contrast CT scan of the chest. Do your non-contrast CT scan of the chest, looking at the lung parenchyma. So depending on the pattern, you can have a lobar distribution in which you are going to see opacity affecting a certain lobe. So you see a patient having a lobar opacity, that's a lobar pneumonia. You think of strep pneumo. Sometimes it can be bronchial, just part is a patchy segment, just some segment, in a patchy pattern of the bronchioles are affected with the adjacent alveoli. That's bronchial pneumonia. Sometimes it can be interstitial in distribution. You just see that they are affecting the tissue in between the alveoli. So interstitial, you think about all those atypical organisms. So this one now is lobar because it's kind of, you can see the haziness there, taking care of the lower aspect of the left lobe. So how do you manage? Them? So the severity of the illness determines the best management setting, either inpatient or outpatient. So what I'm going to say here is that basically we have like two major types or three major types of pneumonia. We have the community-acquired pneumonia, in which the person is presenting with the symptoms outside the hospital setting, in their house, in their school, anywhere outside the hospital. But if the person is having that symptom in the hospital setting, that is hospital-related pneumonia, hospital-acquired pneumonia. Usually, if the person has been in the hospital for more than 48 hours, hospital-acquired pneumonia, more than 48 hours. An example of hospital-acquired is ventilator-associated pneumonia. So if the person is being placed on ventilator for more than what hour? I think I mentioned it when we were talking about mechanical ventilation. Anybody remembers?
I think 24 to 48 hours.
48 hours.
Yes.
72.
No, it is 48. It is
Yeah.
48. Everything is 48. So if the person is placed in the ventilator after 48 hours and the person starts developing features of pneumonia, that is ventilator associated pneumonia. So, but we are going to be focused more on we look at everything. For the community acquired, you want to do what you call the COP65 scoring. So it's going to tell you if you are going to admit that patient or not. So the COP65, the C is standing for neurological stuffs, confusion. So is person disoriented? Is he having impaired consciousness? 1 point. Urea, what is the level of the urea? Is it more than 7 millimole per liter or greater than 20 milligram per day? 1 point. 20 milligram per day, 1 point, or 7 millimole per liter. Please take note of the unit so that you don't get confused. Some people, they might put 7 milligram per day, and some people will think it is millimole, and they want remove that point. So it is 7 millimole, 20 milligram. Respiratory rate, that's the R. Is it more than 30 cycles per minute? Is it more than equal to 30 cycles per minute? You give 1 point. The blood pressure, is systolic 90, or the diastolic is less than 60, or the systolic is less than 90? You give 1 point. Then is the person 65 above? You give another 1 point. So that's the COP65. 5 parameters. So the score you get is going to tell you what to do. So if you get a score between 0 and 1, you know that this is not a very severe condition. So you treat the patient as outpatient. If you get a score of 2, 2, 2, you hospitalize. If you get a score of 3 above, you hospitalize, but not on the medical floor. You hospitalize to ICU straight. Hospitalized to ICU straight. Hospitalized to ICU straight. If the COP score is 3 above. So, so for patients that has been treated in the outpatient setting, you might want to evaluate them by doing your rapid influenza test, to know if they will need oseltamivir, which is an antiviral that you have to administer within 48 hours. So it depends on the presentation. So if you get the history that this person has had, prior history of something that looks like viral, runny nose, sore throat, malaria, headache, and suddenly the person starts developing, high fever, cough, productive cough, you know that it's likely to be that this person had a viral infection that became, you know, um, contaminated with bacterial infection. So there is a superimposed secondary bacterial infection on a primary viral infection. So you might want to rule out influenza by doing the testing. And if the person presented within 48 hours, you can add oseltamivir to the treatment. So otherwise, no additional workup is needed. Unless there's failure to respond to treatment, maybe you now treat the bacterial stuff is not working, you might want to evaluate for influenza. Or if sorry, not influenza, for other organism, for other things which we are going to talk about. Or if the person has any risk factor for any resistant organisms, like the person has structural lung disease or recent hospitalization. It could be that these individuals have drug-resistant pneumonia, drug-resistant pseudomonas causing pneumonia, drug-resistant pseudomonas causing pneumonia, or the person has MRSA. So they are very common in people that have been recently hospitalized, or people with structural lung disease. We know that people with structural lung disease, they can have like cystic fibrosis, like bronchiectasis, they can have staph aureus infection and pseudomonas. But what I want us to always put at the back of our mind should be pseudomonas number 1, pseudomonas number 1, pseudomonas number 1, pseudomonas number 1. So um so most of the time, people with structural lung disease, they will not respond. They might not respond to initial treatment because you need to treat the underlying cause before you can settle that patient. So for patients treated in the hospital, you have to obtain blood cultures and of course sputum gram stain after you have done your X-ray. Don't pick blood culture or sputum gram stain first. Pick chest X-ray first. Pick chest X-ray first. So, and of course, because of this is the hospital setting, aside pseudomonas, aside staph aureus or CLEP, we also have some other things that is very common in the hospital setting that you must rule out. Legionella is another word. Although most of the time they put Legionella in people that are doing water surfing, cruise ships, air-conditioned area. But Legionella is also very common in hospital setting. Some of those viruses too, they are common in hospital setting, and streptococcal pneumonia. So you have to do a urine streptococcal antigen test, in the setting of the hospital. So don't forget viruses, Legionella, and strep pneumo. Although most of them don't typically test this, but it's good to know it. So so this is a gram stain showing gram positive cocci. So this suggests it for it's likely to be staph aureus. So this is gram stain for, it's not very clear, but we can see that it's diplococci. So this is going to be strep pneumo. So testing for atypical organisms, those that are difficult to culture on standard culture, you have to put them on the specific agar that they need. For example, people with mycoplasma, you put them in the eating agar, and the like before you can grow them. So a 70-year-old man presents to the emergency department with 5 days history of fever, productive cough, altered mental status. So it's found to be hypotensive and tachypneic. Broad spectrum antibiotics and fluid resuscitation are promptly administered. Broad spectrum antibiotics, fluid, but the patient continues to be hypotensive. What is the best next step in treatment? What do you think this patient has? Anybody? Fever?
Typical anemia.
Yes, it is typical. What else? What else?
Sepsis.
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 Oh, it might be
Sepsis. So this person is having septic shock. So of
yeah,
course we need to
sepsis. Yeah.
Admit,
give. Huh?
admit, admit
Yes,
patient.
definitely we have to admit. And we need to
Mhm.
place on inotropes, vasopressor to bring up this blood pressure and probably mechanically ventilate. So separating the etiology based on the typical nature. So we have typical bacteria, we know them already. Strep pneumo, influenza, Staph aureus, and the gas. We don't need to actually learn. We just need to focus on the important ones. We can't learn everything. They are a lot. They are very much. So for the atypical ones, you already know them. Legionella, Mycoplasma, Chlamydia, pneumonia, as well as Chlamydia psittaci. So I've given us what to look out for Legionella: water bodies, aerosol, AC, water cruise. Sometimes in the hospital, Legionella. Mycoplasma, young person, having some form of confinement, military barrack, dormitory, think about mycoplasma. Yeah. So respiratory viruses, influenza A, B, your SARS-CoV, the rhino, parainfluenza, adeno, all of them, they can cause pneumonia too. So what are some certain conditions that can predispose to pneumonia? Alcohol, we just need to remember strep pneumo, CLEP, and the oral anaerobes. People with alcohol use disorder typically have Klebsiella infection. It can cause immunosuppression, which can explain the reason why they can have strep pneumo. Strep pneumo is the commonest cause of community-acquired pneumonia, number one, and it's very, very common in people with immunosuppression. So alcohol use can also, be shared with oral anaerobe because these guys they can lose control and they can aspirate. So they can have infection from the oral anaerobes. Although, even the commonest organism that is still isolated in aspiration pneumonia is still your gram-positive strep pneumo. It's still strep pneumo. No, don't go and pick oral anaerobes, please. You are going to still give antibiotic first for your gram-positive like strep pneumo. Then, if you notice that the person has a lung abscess or the person has empyema, then you can now add coverage for your oral anaerobes. Simple as that. So, aspiration pneumonia. So we have it here. Common organisms, I share with aspiration pneumonia, strep pneumo, Staph aureus, strep pneumo, Staph aureus, the gram-positive. Don't forget. Don't say oral anaerobes first. Sometimes it can be mixed with the anaerobes. So there's something we call aspiration pneumonitis, in which an individual maybe loses consciousness or being intubated, or person had a stroke and person aspirated, and the person takes in the gastric acid into the airway. So they typically have these symptoms of bronchospasms, uh, difficulty in breathing, wheezing, more like, just think about features of like as if the airway is kind of obstructed, like asthma, bronchospasm, difficulty in breathing, wheezing. That's what they have. So in this kind of individuals, you don't want to give them antibiotics. Don't give them antibiotics. So what you do is that, and we are not seeing anything that's suggestive of infection, productive cough, and all those things. So you know that, okay, this is likely to be aspiration pneumonitis. And of course, the onset is going to be acute. It's going to almost follow that event immediately. So that's not the time to think about aspiration pneumonia. So somebody strokes right now, or the person had seizure or something just acutely, and the person start developing bronchospasm, dyspnea, wheezing, that's not the time to think about aspiration pneumonia. That is aspiration pneumonitis. The acid is being aspirated. So what you do is supportive treatment. Just give immediate suctioning, give oxygen, and if there's a need, you can give the bronchodilators. The person is going to come back because it's self-limiting. You don't give antibiotics. But later on, the bacteria can now be introduced, and the person will now start having features of aspiration pneumonia, fever, shortness of breath, cough, which may be productive. And if it's contaminated with the anaerobes, it can be foul smelling. So you have to give the appropriate medication. But if you don't have anything that is suggestive of lung abscess, it's not foul smelling, you looked at the x-ray, you are not seeing any hair fluid level, you don't have any lung abscess. So you don't need to give coverage for anaerobes. Otherwise, you only give coverage for your gram-positive, the strep pneumo, and the staph aureus. So you just give your ceftriaxone, azithromycin, ceftriaxone plus your macrolide, ceftriaxone plus your macrolide. But if you have anything that's suggestive of lung abscess or empyema, that's when you now give coverage for the anaerobes, which is ampicillin sulbactam. And give ampicillin sulbactam, you can give moxifloxacin, and some other agents like that. But the commonly tested one is ampicillin sulbactam for the gram-positive, for the anaerobes, or you can give clindamycin. So I think I have a pinned image here to show us the risk factor for aspiration pneumonia based on the problems. So if there's reduced consciousness, either the person is on sedatives, illicit drugs, anesthesia, generalized seizure, and aspirate. Dysphagia, think about dysphagia, problems with swallowing. Dysphagia can be neurologic, those neurologic disorders can cause dysphagia, what's it called? Esophageal motility problems, scleroderma, the likes, protracted vomiting, gastroesophageal reflux, or the person has a tumor. Even if the person has a tumor, it can lead to dysphagia and they can have aspiration pneumonia. Pharyngeal or glottal dysfunction, either the person is on tracheostomy or intubation and you have a lot of secretion pooling within that area, it can lead to aspiration pneumonia. Now, so gastric tube feeding too can disrupt the integrity of our sphincters, leading to aspiration pneumonia. Dental issues, very common in people with gingivitis, poor dental hygiene. They can easily have aspiration of the microbes in the mouth into the airway, leading to aspiration pneumonia. So think about loss of consciousness or decreased consciousness, stroke, seizure, trauma. Think about the response to the loss of consciousness. You want to intubate. Intubation too can cause it. You want to put tracheostomy tube. You want to feed NG tube, can cause it. Think about dysphagia, cannot swallow properly. Nervous control. Advanced form of people with myasthenia gravis, Lambert 18, dysphagia, or ossifragia dysmotility, scleroderma, obstruction by tumor, GERD, all of them, can lead to aspiration pneumonia. Even use of antipsychotics. People that are using antipsychotics that have anticholinergic, antihistamic effect. The antihistaminic can make them dizzy, they can be sedated. The anticholinergic one will reduce saliva secretion. They are going to have a dry mouth, and it is going to be very, very difficult for them to form a food bolus when they are eating. So they can easily aspirate because it's very, very difficult to swallow when you don't properly moisten that food into a bolus to swallow. So watch out for that. So for the aspiration, we already know what to think about. The gram positives, sometimes the enterics and the oral anaerobes. Please forget the part that is not included here. It is there. COPD. You think about We already know the two vaccines we give in COPD. Give vaccines for strep pneumo, we give vaccine for influenza virus. Then H influenza is also a big problem in them. H influenza, strep pneumo, and the influenza itself. Pseudomonas too. Okay. Exposure to animals. Birds, avian influenza, Chlamydia psittaci. Psittaci is a problem of parrots. Avian influenza can come from birds. People that are exposed to bird and bats that like to explore caves can get exposed to Histoplasma capsulatum, which can cause pneumonia. People they can have coccidioidomycosis pneumonia, caves explorer. People that are very close to rabbits, rabbit rearers, they can have Francisella tularensis. Farm animals, Coxella bonnetti, Coxella bonnetti. So HIV people, immunosuppression, the number one guy. Strep pneumo, strep pneumo, strep pneumo. And of course, most importantly, pneumocystic girovecti, pneumocystic girovecti. Sometimes they can have cryptococcus pneumonia, meningitis. So cryptococcus can cause meningitis, it can cause pneumonia too. Histoplasma and almost all the other fungi, they are very common in people that has background immunosuppression. Histoplasma doesn't typically manifest in people that are immunocompetent. So if you are immunosuppressed and you are exploring caves, person is toying with histoplasma. So think about strep pneumo, pneumocystic, histoplasma, aspergillus, which we are going to talk about properly, and Mycobacterium tuberculosis sometimes. But I don't like mentioning this so that we don't get confused. Nobody is going to be testing Mycobacterium tuberculosis causing pneumonia. So just focus on histoplasma, aspergillus, pneumocystic girovecti, strep pneumo. Recent travel, hotel people, cruise ships, chop life gang. Think about Legionella. Think about Legionella. Southwest United States, California, coccidioidomycosis. Southeast Asia, Burkholderia. Okay, well, I don't know. This is not something that is very frequent, but Southwest US, hotel, cruise, Legionella, they are very important. They are very, very important. Middle East Asia, they can have the Middle East respiratory syndrome coronavirus, the MERS coronavirus in the Middle East. Structural lung disease, cystic fibrosis particularly. Okay, you think about, depending on the age, Pseudomonas in the young, Staph aureus, in people that are older, then Burkholderia cepacia too. Post-viral. So post-viral, after viral infection, influenza
Sorry, Dr.
virus.
Bobo, did you say the staff is in the older or in younger age?
Sorry, staph should be in the young.
Vaccine.
Staph is in the young.
Yeah.
Pseudomonas is in the old. Sorry about that. So post-viral influenza, most commonly your gram positives, staphylococcus and strep pneumo. They usually follow influenza most of the time. Staphylococcus and strep pneumo, commonly strep pneumo, post-viral, particularly influenza. Intravenous drug users, think about Staph aureus. Because these people, they are going to inject through their skin, and you have Staph aureus too in the skin, so they can easily inoculate the Staph aureus, and that's why it can also cause endocarditis. Some of them will be immunosuppressed. People that are injecting drugs. That's why it's a risk factor for TB, it's a risk factor for HIV. So you can also consider strep pneumo. Endobronchial obstruction. Obstruction is going to lead to aspiration, just like I have here. So think about the agent in aspiration. Strep pneumo. Think about the other gram-positive Staph aureus. Think about anaerobes. So empiric treatment antibiotic is depending on the severity. So it's going to depend on your COP65 scoring. Yeah, that is going to give us an idea of the antibiotics to use. if you are going to treat somebody on outpatient basis, there's an antibiotic that is going to use. If you are going to treat outpatient, but the person has some comorbidities, there's an antibiotic that you are going to use. If you are going to admit somebody into the hospital medical floor, there's an antibiotic. If you are going to admit to the hospital but straight to ICU, there's an antibiotic. If you are going to place on mechanical ventilator in the hospital, antibiotic. So that's what we are going to look at now. So for immunocompromised patients, and those with strong structural lung disease like cystic fibrosis, like bronchiectasis, they have a very high risk of developing Pseudomonas pneumonia. So immunocompromised and people with structural lung disease, cystic fibrosis, bronchiectasis, you have to consider Pseudomonas in them. So you have to introduce anti-Pseudomonas beta-lactam, which is piperacillin tazobactam. If you have not mentioned this antibiotic, you have said nothing. So piperacillin tazobactam has to be there, plus a respiratory fluoroquinolone or a macrolide. So either we are combining piperacillin tazobactam with levofloxacin, or we are combining piperacillin tazobactam with azithromycin. That's for Pseudomonas. So don't forget, immunocompromised, people with structural lung disease, bronchiectasis and cystic fibrosis, you have to consider Pseudomonas as a cause. So this is a summary of the best initial treatment. So that's what they usually test. They test the best initial empiric treatment that you are going to give based on the patient profile. So if we did our COP65 and the patient fell into category of 0 to 1, definitely that is outpatient. So if the person is being treated outpatient, the person is less than 65 years, the person is okay, healthy, no problem. So this is what we use: amoxicillin or doxy or macrolide. Why? Because the suspected agent in that category of people usually falls within this: strep pneumo or the other atypicals. So because of strep pneumo, you can use amoxicillin depending on the presentation. So if the person is, in addition to having this portfolio, the person is having productive cough, fever, acute onset, it's likely to be strep pneumo. So you want to give amoxicillin only. But if it's otherwise, person is having dry cough, malaria, so you are thinking of either one of these, and the person is having the cough score of 0 to 1. So either one of these, so you can give doxycycline or macrolide in that situation. So just think about amoxicillin and doxy for the first category: amoxicillin or doxy. For the other ones, you don't need to memorize the organism. You don't need to know them. So the next category is people with this same profile, but which is outpatient management, but they are more than 65, or they have comorbidities like COPD, diabetes, malignancy, heart failure, anyone you can think of, any comorbidity. You don't need to memorize anything here. Forget about this. What you just need to know is that you need to give them beta-lactam plus macrolide or fluoroquinolone. Once you know that, you have known all the algorithm. Beta-lactam plus it has to go together. Ceftriaxone plus azithromycin. You'll be seeing it in options very well. Ceftriaxone plus azithro. That is beta-lactam plus the macrolide or fluoroquinolone. So you are not combining the fluoroquinolone with anything. And mind you, you are using a respiratory fluoroquinolone like levofloxacin. So what is it called? So beta-lactam plus macrolide or fluoroquinolone for individuals with outpatient treatment, but they are more than 65 or they have some underlying comorbidity. Yeah. So for people with community acquired, but they are not being managed outpatient, we have to hospitalize them and put them on the medical floor. We don't need to worry ourselves. We will still give them the same management as the number 2, our beta-lactam plus macrolide or a respiratory fluoroquinolone. We can see that it's very easy. We don't have to be a genius to know this. Then the next category is community acquired pneumonia requiring ICU. So what you just do in this category is that we already know that we are using beta-lactam plus macrolide or ordinary fluoroquinolone. So what we do is that in these ICU people, we must keep beta-lactam involved. That's the code. You must keep beta-lactam involved. So you either give them beta-lactam plus a macrolide or beta-lactam plus fluoroquinolone. ICU. That is all. And you remember ICU category are people with 3 above. Now, that is for community acquired. Anybody that you are suspecting hospital acquired, that is, the person developed the pneumonia in the hospital after 48 hours of admission, that is hospital acquired pneumonia. The common agent, like we have said, is what? Pseudomonas, is what? Staph aureus, is what? Legionella. So you have to give agents that can help you take care of this, particularly Pseudomonas. So you have to start with an anti-pseudomonal agent. You can start with, commonly, the one they usually start with is our piperacillin tazobactam. Start with it, piperacillin tazobactam. That is just because you are thinking the person is hospital acquired. The person has hospital acquired pneumonia. That's why you just start with your anti-pseudomonal agent. Now, if you now think that this person has a structural heart disease, the person has cystic fibrosis or bronchiectasis, so that means that is even further narrowing your stuff to pseudomonas. So you have to double agent. You have to use a double agent in that situation. You have to double your anti-pseudomonal protection. So in that category of people, you have to give pseudomonas, what's it called? What am I saying? Your piperacillin tazobactam with a fluoroquinolone, because fluoroquinolones too can cover for pseudomonas. Mind you, before I leave, please, you don't use fluoroquinolone in individuals that are elderly. So here now, 65 years, instead of using fluoroquinolone monotherapy, you will not choose that. You would rather go for your cephalosporin plus your macrolide, because fluoroquinolone can tilt them to having Clostridium difficile pseudomembranous colitis. They can have rupture of tendon. We remember from our microbiology. At the same time, they have a very high risk of having aortic dissection. So you don't use fluoroquinolone in people that are old. So hospital-acquired pneumonia, you have confirmed this person develops this pneumonia after 48 hours of admission. I have to give anti-pseudomonal agent, piperacillin tazobactam. Oh, this person, in addition to that, has structural lung disease, cystic fibrosis, bronchitis. I have to add another pseudomonal agent. So level with piperacillin. Oh, this patient is critically ill, needing ventilatory support, or the person is in septic shock because the person has a very high chance of mortality. So in addition to that double agent of pseudomonas, you have to give coverage for MRSA. You have to give coverage for MRSA, which is what? Using, anybody remembers any anti-MRSA agent? Anybody remembers?
Vancomycin.
Vancomycin, or which one else? Which one again? Which one
Mm,
again?
mm,
Which one?
Is it
Anybody?
Linezolid?
Yes.
Yes. Linezolid,
Linezolid.
linezolid, or vancomycin. So that's the 3 algorithm. You are starting with anti-pseudomonas, structural lung disease, add another anti-pseudomonas, ventilatory support or septic shock, in which a person has a very high chance of dying, give an anti-MRSA with it. Very easy algorithm. I think we should be able to say this algorithm to ourselves. Or is it confusing?
Yes, so
Yes, it is confusing.
It's confusing. Maybe we rehearse. Let's rehearse together.
We rehearse again.
But I have a question, please. So in the for the last group, patients with hospital acquired, you add so if you're adding piperacillin tazobactam, you're also gonna add another piperacillin tazobactam, or
No.
piperacillin tazobactam plus fluoroquinolone,
Plus fluoroquinolone. Or
then
you can use
anti-mesa.
other anti-pseudomonal agents, but other like
Okay.
aminoglycoside. Do you get? But the common one that they use, piperacillin, now come with fluoroquinolone. Patient is all right. So
Mhm.
so we can rehearse together. Two
sorry, is
categories.
vancomycin not anti-pseudomonas?
No. No, I'm not sure it's there. No, it's not there. It's not there. Vancomycin is not there. The ones that are there, you talk about piperazine, tazobactam.
Piperazine
You talk
and
about
cefoxitin,
you talk about third generation
them
cephalosporin.
cyclo.
Yes, you talk
Okay,
about
like
your
ceftazidime.
carbapenems.
Mm.
You talk about your carbapenems, imipenem, penem, all those ones. You talk about aminoglycosides. You talk about which one is respiratory fluoroquinolones. We
And
can
third
check on more,
generation.
but
Okay.
vancomycin is not there. Vancomycin is strictly MRSA. It's very good for MRSA, vancomycin. So the first algorithm is talking about
Sorry, but well, let's see if you're using if you're using amoxicillin, I want to cover for pseudomonas. You don't use it alone. I think you combine it with either antipseudo, tazobactam, or sulbactam.
yeah. When I was saying piperazine, I was not stressed. I don't want to be stressing myself. I assume that you guys already know. Do you get like
Mm.
when I say piperazine, I don't mean piperazine alone. No. If piperazine tazobactam, but pronouncing that name is stressful. Do you get? So that's why I'm just saying piperazine. So I actually meant piperazine tazobactam. It's a combination. That's the way you use it. That's the way it comes. So people that you have seen that this community acquired LD less than 65 years, you know that the cost is like your strep pneumo or your atypical. So two things you can give them. Give them drugs for the strep pneumo. That is amoxicillin. Depending on the presentation, productive cough, all those things that we've seen that it's likely to be strep pneumo, give amoxicillin. If it's tilting towards atypical and it is community acquired and the person is less than 65, LD, atypical, give your doxy or your macrolide to cover for your mycoplasma pneumoniae or your chlamydia pneumoniae. That's first category. Second category is still that community acquired, but still the same outpatient, but the person is more than 65. The person is having comorbidity, it's not healthy. Comorbidity. That's when you now start doing your beta lactam plus your macrolide or fluoroquinolone monotherapy. Just know those two, you are okay. The next category is people with community acquired, but they require hospitalization. This is not outpatient. They require hospitalization. The same treatment as people with community acquired, outpatient, but with comorbidity. You are giving your beta lactam plus macrolide or single fluoroquinolone monotherapy. The next category is community acquired, but ICU, not hospital. ICU straight. So here we have said it. You have to keep your beta lactam involved. Beta lactam plus macrolide, beta lactam plus fluoroquinolone, anyone. Then the last one is now talking about hospital-acquired pneumonia, not community-acquired. Hospital-acquired pseudomonas is the implicating agent, commonest implicating agent. So if the person doesn't have any structural disease, the person does in shock, no ventilator support, just give a single anti-pseudomonal agent like piperacillin, tazobactam. The person has any underlying stuff that can tilt the person towards pseudomonas, you have to double it. Piperacillin taxol plus a respiratory fluoroquinolone or aminoglycoside or all those things. If the person needs ventilator support or the person is in septic shock, that mortality rate is high. So you need to get coverage for MRSA. So you use your double anti-pseudomonal agent with MRSA, which is vancomycin or linezolid. Did we get that algorithm? Don't worry. I know
Yes.
that
Yes.
with time,
Yes.
it's going to be smooth in our head. So, so pneumococcal vaccine should be given to all children less than 5 years or elderly people more than 65 years. That's number one. You have to give pneumococcal vaccine in everybody with chronic heart disease, chronic lung disease, any chronic disease, kidney, lung, heart, anyone, diabetes, you have to give them. People that are smoking, they all have increased chance of having pseudomonal infection. Give them asplenia, what's encapsulated organism problem. Give them. people with congenital deficiency malignans, give them. CSF leakage is very common. Pseudomonal strep pneumococcal infection is very common in people with CSF leakage. It can cause meningitis, which is usually associated with deafness. So you have to give them meningococcal vaccine. People with cochlear implants. So studies have shown that people who wear cochlear implants, they develop pneumococcal infection. Give them pneumococcal vaccine. So the next one is influenza. So influenza, talking about the atypical ones, influenza is highly contagious automyxovirus. One thing we said about the automyxovirus in step 1, anybody remembers? Automyxovirus. What's spectacular about them? They are what? They are
What did you
Is it?
call them? Auto what?
automyxovirus.
Okay. Automyxovirus.
What do we remember about Boa?
Oh yeah.
Oh, okay, yeah. They
Segmented.
are segmented.
They are segmented.
There's
So
Yeah.
we have 3 major
And
types. ABC.
Oh,
So
okay.
different types. For A now, the common ones that typically cause infection is A and B. C is rare. So for A now, 2 different types, many types actually, but common ones, H1N1, H5N1, H1. So this is just talking about the different types of their hemagglutinin, glycoprotein, and the neuraminidase gene that they have. Two phenomena are shared with influenza: antigenic drift, antigenic shift. So antigenic shift is severe than antigenic drift. What is happening in the antigenic drift? You are just having point mutation in this protein and this protein. You're just changing an amino acid, substituting like a nucleotide base. You just do a little change in the structure. The influenza virus need the hemagglutinin to bind to the salic acid of the respiratory membrane to enter into the host. While after replicating, after forming new buds, when the buds are attached to the membrane, they need to cleave um, uh, um, neuramic acid molecules so that they can release them into new host. So it helps them cleave off those new buds so that they can gain entry into new hosts, neuraminidase. So they can have point mutation within this protein and it can change them in a little way. That is antigenic drift. Small point mutation changes in the sequence of gene that codes for hemagglutinin, sequence of gene that codes for neuraminidase, and that can lead to some epidemics. An individual can get infected with influenza multiple times because when there's point mutation, the one that has previously infected is different from the one that is newly infecting. They are changing point mutation. But for antigenic shift, the problem or what is causing this is not due to small point mutation. No, you are having let's say, okay, let me give an example. This is one particular influenza virus, H5N1. This H5N1 can undergo many point mutation, but it will still be H5N1. But in antigenic shift, you have human influenza mixing with avian influenza. For example, H5, let's say it's human, and H1N1, it is avian for birds. They can come together, undergo what we call gene reassortment. When they resort that gene, they change it, they sort it in different ways. They can form another new subtype. That new subtype can be H2N1. That's different, totally. It has not been seen before. So that is going to cause a more severe problem, which can lead to pandemic. So antigenic shift is due to gene reassortment leading to pandemic, while antigenic drift is just due to point mutation leading to epidemics. In the US, typical influenza season starts from the winter, November to April. Yearly vaccination for inactivated influenza virus is recommended for all patients more than 6 months of age. You have to give them that vaccine. So they take it twice. If they are between 6 months to 8 years, you have to give them twice. But if it's adults, they don't take it. Just give them one dose, high dose, for people that are more than 65 years, or people that are immunocompromised. Just give them high dose. People with COPD, remember, people with COPD, they have to take annual influenza viral. But people between the age of 6 months to 8 years, they have to just take it twice. Between that time, you can give it 4 weeks apart. That's all. But people that are more than 65, immunocompromised, COPD, give them annually high dose influenza vaccine by injection. Don't forget, it is inactivated influenza, not the intranasal one that's activated. You give the injection one, which is inactivated. How do you know that what this person is bringing in is likely to be influenza? They are going to have an abrupt onset of fever, high-grade fever, number one. They are going to have some constitutional symptoms like malaria, headaches, chills, cough that is not going to be productive, coryza, sneezing, rhinorrhea, weakness. So once you see chills, malaria, coryza, runny nose, sudden onset fever, you are thinking of probably viral infection from influenza. So some other patients might have confusion, because of their weak immunity to combat that virus. So it causes problem in people with immunosuppressed states. What is the best next step to investigate? If you are going to need investigation, you have to do a rapid influenza test of the nasopharyngeal swab. So it is a rapid test that you do to make your initial diagnosis. To be sure of what you are dealing with, you have to do direct fluorescent antibody test or viral culture or PCR. You don't need to actually remember this. Nobody's going to ask, but just for knowing sake, you can do your direct fluorescent antibody test, viral culture or your PCR, to make diagnosis of influenza. The common test is the rapid influenza test. But if this individual has no risk factor for I thought I have it here. Oh God, where is this thing? I have the okay, yeah. So, but if they have no risk factor for complication, you don't need to be doing your diagnosis and be doing rapid influenza. Just treat them symptomatically and you move. And what are these risk factors for severe complication of influenza? So I put in the word caption. C for chronic disease, anybody with diabetes, COPD, sickle cell, malignancy. A, age more than 65. P, pregnancy or 2 weeks postpartum. T is for nothing. I, immunosuppression. O for obesity. N is for nothing. So, caption, chronic disease, 65, pregnancy, immunosuppression, obesity. They have a high chance of developing serious complication of influenza virus infection, which includes ARDS, sinusitis, bronchitis. It can affect the heart, myocarditis and pericarditis. It can affect the brain, encephalitis. It can even affect the muscles, myositis, rhabdomyolysis. It can cause exacerbation of COPD and asthma. They can be secondary bacterial infection. And the bacteria we are talking about here, anybody remembers the bacteria that superimpose on someone that has influenza? Which one?
Strep.
Strep pneumo.
Strep and
Or
Strep or staphylococcus.
staphylococcus.
Yeah.
So in these people, anybody that have caption, we must make our diagnosis and be sure of what we are dealing with. And once we know what we are dealing with, we can now give antiviral compulsorily. You must give antiviral in anybody that has comorbidity that can be exposed to severe form of influenza, regardless of the duration where you are catching it. You must give antiviral, which is oseltamivir or zanamivir. But if this person has no risk factor for severe form of influenza, you just treat symptomatically, give analgesics, give antibiotics, hydrate, and the person moves. But if you catch that person too within 2 days, within 48 hours, you can give your cetamivir or your zanamivir. But if that person
That's
has
sorry. So is it if you catch the person, both those that have comorbidities or not, you still give oseltamivir?
no, no,
No.
no. So
That's one.
if you catch the person within 48 hours, regardless of the status, if there is no comorbidity or there's comorbidity, give oseltamivir or zanamivir because it's going to shorten the duration of infection.
Mm-hmm.
But if you find out that this person has comorbidity, which is caption, if you catch the person at 100 days, give your cetamivir and your zanamivir to avoid that complication from happening, even if it has passed that 2 days window. Do you get that, Dr. Antonia?
Yes.
So that's the way it works. That's the way it works. So we have known the complication: ARDS, bacterial infection, sinusitis, pericarditis, and encephalitis. So moving on to aspergillosis.
So sorry. So in this group of people in the caption, do you still need to do the flu testing?
Yes, you need to do flu testing. Yeah,
Mhm.
you need to do flu testing in there to be sure that what you are dealing with is influenza. You need to do your flu testing. Very important. So, aspergillosis, group of disease caused by aspergillus. We know that aspergillus appear 45-degree with branched septate hyphae on microscopy. Very, very important. It's caused by Aspergillus fumigatus. They have different spectrum. We have talked about allergic bronchopulmonary aspergillosis, which is a type 1 hypersensitivity common in people with background COPD, background CF, cystic fibrosis, and asthma. People with allergic bronchopulmonary aspergillosis usually have background asthma or COPD. So we have already trashed it already. So aspergilloma is part of the complication of ABPA, and what typically happens in aspergilloma is that you just have a fungal ball occupying a cavity within the chest wall. So the individual probably had previous infection like maybe histoplasmosis or tuberculosis that has left a cavity in that chest. You can have aspergilloma forming within that cavity. Most of the time, they are quiescent, they don't have any symptom, or they can just have hemoptysis when it's big enough to rupture into the bronchial vessels. They don't typically have fever, cough, and other symptoms of aspergillosis. So, one way you can investigate is by doing your chest X-ray or your CT, and it's going to show you the mass occupying the cavity. You can see this mass here occupying this cavity. And when you do your imaging, you will notice that the mass shifts with repositioning. So as you are changing where like the cubic does, where stand up, where supine, where prone, is going to be changing with repositioning. It further supports diagnosis of aspergilloma. What are you going to do? This person has aspergilloma. You can do your surgical resection, remove it, remove it, remove it. You can do your surgical resection. Most of the time, the antifungals might not be effective. So you have to go in, remove it. And if the person eventually develops hemoptysis from bronchial erosion, you need to do bronchial embolization to stop it. To stop it. So chronic necrotizing pulmonary aspergillosis is like the big term. And aspergilloma is under chronic pulmonary aspergillosis. It's just a quiescent form. But when it's not quiescent, when it's not silent and it's causing problem, it's the chronic pulmonary aspergillosis. So it's very common in people with what's it called? Disease which leads to formation of cavity, just like aspergilloma, like tuberculosis, like histoplasmosis. But in these people, we are going to be having symptoms for at least 3 months, which includes fever, cough, hemoptysis, night sweat with background immunosuppression. Very, very important. So there's background immunosuppression, there's fungal ball, or there's cavitary lesion within that chest, and the person is showing symptoms. That is chronic necrotizing pulmonary aspergillosis. So you can give voriconazole to quieten those symptoms. Sometimes you can do surgical resection, if it's severe and it's localized. That's chronic necrotizing pulmonary aspergillosis. It's very similar to aspergilloma. So,
So, sorry, see, you said it's usually poison
the what?
for the chronic necrotizing.
No,
Do you
they are
say
not.
it's
They are not quiescent. They are not silent. They are symptomatic. See, I have it here. See, fever, cough, hemoptysis, drenching night sweat, fatigue for at least 3 months, and you did your
it's
imaging.
not the same symptoms with TB?
Yes, same symptoms with TB. Yeah.
So how do you differentiate by diagnosis?
Yeah, so you can only differentiate by doing your diagnosis. And I think I mentioned diagnosis last time. So you can do culture, but culture will waste time. You can do serology, looking for IgG to aspergillosis. So once you see IgG to aspergillosis, you can think of this. And of course, you want to give your voriconazole, or if indicated, very severe form, you do your surgical resection. But don't forget, they are going to be symptomatic. So once you see symptom with cavity, think about this. And of course, there's going to be background immunosuppression. Think about chronic necrotizing pulmonary aspergillosis. The third one is invasive pulmonary aspergillosis. So this one, very common in people with background immunosuppression too. But you are not going to see any cavity. So immunosuppression from chemotherapy, from neutropenia, from leukemia, having transplants, whatever the cause of the immunosuppression is going to be there. And the typical triad you see is fever, chest pain, and cough. They are going to have that. But how you can nail this diagnosis by you are doing your assay for your component of the cell wall of the fungi. Don't forget, in chronic pulmonary aspergillosis, what you are checking for is IgG to aspergillus organism, right? But in invasive, you are doing, and you can do culture in the 3. You can do culture in the 3. Like you can do your culture. Anybody remembers the starting test? Let me tax our brain. Anybody remember the starting test we do to make diagnosis of allergic bronchopulmonary aspergillosis? What's the first thing? Anybody remembers?
You start
So
with
Eosinophils, maybe.
the IgE.
antibodies.
The what?
ESR. ESR eosinophils.
No,
ESR.
IgE. Immunoglobulin too.
IG antibodies.
Okay.
IgE
Or IgE antibodies, or
Is that test?
eosinophil
the which
or
one?
the
The skin
eosinophils.
Yes.
Skin
The
test.
skin test. The skin
Mhm.
prick test. So once you now do that, you now quantify your IgE. You do your precipitin panel. You do your
the field
eosinophil count.
count.
You know your eosinophil count has to be more than 500, right?
500. Yes.
500. Eosinophils in the sputum, you have to be more than 25%. So once you see that, you know that's in keeping with your eosinophilic stuff. If you do this sputum analysis, you are going to see other features of eosinophilia like the Charcot-Leyden crystals.
Cells.
Yeah. So that's ABP.
So, Dr. Bobo, the difference now between aspergilloma and the chronic pulmonary aspergillosis is that both have cavities, but one contains a tumor, a growth. Then the other one doesn't contain. And the chronic pulmonary one is symptomatic too.
Yes, that is it.
Basically, the difference.
That is it. It's going to be symptomatic. Yes. So
So aspergilloma is not symptomatic. It's just the cavity deletion.
yes, most of the time they don't have any symptom. But
Okay.
sometimes when the
They
ball
want
erodes into the bronchial vessels, they can have hemoptysis. So
Okay.
that's it.
So it's just then from your blood findings, right? From your laboratory findings too.
Yes, then from the laboratory findings, you corroborate with the laboratory findings. Yes.
Okay.
So invasive pulmonary aspergillosis, um,
No, it's not laboratory test, so it's CT chest X-ray. That's where you find aspergilloma because they said the laboratory tests are typically normal. For
what?
aspergilloma,
The
for
what?
aspergilloma, they said the laboratory tests are normal. So for you to get aspergilloma is CT or chest X-ray.
Yes,
That's why.
yes. No, she was talking about chronic necrotizing.
Oh no, I think she was talking about aspergilloma. I don't know.
Okay.
I think
No,
she was talking about
is aspergilloma I'm talking about.
Aspergilloma she's talking about. So if it's
Okay.
aspergilloma, it's CT chest X-ray. The laboratory tests are normal.
Okay.
Yeah.
Thanks.
So, invasive pulmonary aspergillosis, there's going to be like progressive injury to the lung from the aspergillosis here. And it's very, very common in people with background immunosuppression. So you can have dissemination into the blood and it can go to the other part of the body. It can go to the eyes, it can go to the brain, the bone, the eyes, different parts of the body. And you can use culture to make diagnosis of everything. Chronic necrotizing, invasive, ABPA, like your culture for aspergillus will be positive in all of them. So, but here, in addition to culture, you can do your serum galactomannan assay, or your beta glucan assay. So that's looking for the cell wall components. Serum galactomannan or beta glucan is going to be positive. But the problem is that it is not sensitive. The one you are getting from the serum might not be sensitive. So what you do is that you can do bronchoscopy with bronchoalveolar lavage. So you now subject that to the same test for the galactomannan or the beta glucan, or you just do aspergillus PCR. You are doing the gene sequencing, or you just do a lung biopsy once and for all, to make your diagnosis. So just don't forget about the galactomannan. Don't forget about the galactomannan for the invasive one. The invasive one, galactomannan. You are going to be seeing the halo sign. You are going to see like nodule surrounded by ground glass opacity in your X-ray or your CT. The halo sign, nodule surrounding by ground glass opacity that I've showed us before. Then you confirm by doing your galactomannan. But if you do serum, it might not be sensitive. So you can do bronchoscopy, bronchoalveolar lavage of the collection. Then you check for the galactomannan, or you do your PCR analysis of that. So for invasive, is the one that you have to use voriconazole plus a what? Anybody remembers? Voriconazole plus something. Anybody remembers?
intranasal.
No. You can't
Again,
combine voriconazole with itraconazole.
Steroid.
No.
Voriconazole.
We did not say steroid. We said you are going to combine it with echinocandine, which is
Okay, caspofungin.
capsule
Because
fungi.
that becomes too. That was true.
Yes, you combine it with the capsule fungi. So, so that is that. So you can use steroid, but what I was trying to find out is that combination with the, not that steroid is entirely wrong. Yeah. So voriconazole plus your capsule fungi. Don't forget. So
So
histoplasmosis.
the halo sign, do you see it on imaging?
The which one?
The halo sign you were saying
Yes, the halo
on
sign.
imaging.
You are forgetting. We looked at it that day.
Yeah, it's
yes,
on imaging.
we saw it that day.
The halo, the nodule with the surrounding haziness. That's the ground glass opacity.
Dr. Wale.
Yes, Dr. Olushola.
Okay, I wanted to know if you can hear.
No, I heard you. And I said that reverse halo sign is in one condition. Anybody remembers?
I forgot to know.
Reverse halo sign is in cryptogenic organizing pneumonia.
Organizing pneumonia. Yeah.
So what are the other distinguishing feature for cryptogenic organizing pneumonia?
bilateral migrating inflating opacity.
Nice. That is highly responsive to what? To steroid.
Steroid.
So
Yeah.
it is not
It's not
responsive to antibiotic. Maybe we should
all
take
right.
a break. Let us take like 10 minutes break. We come back and we
Okay.
How long
continue.
when are we finishing, Dr. Bawale?
I want to push it to
Yes, go on and push it because we missed a lot. Let's take a break. No problem.
When are we finishing, Dr. Bawale, please?
yeah, so that's what I'm trying to say. Like I want to push
Sorry,
it
I
to
think it's very important we know, like, we have like a kind of time. So we have like a kind of time frame so
Exactly.
that we can always plan around it. So it's not that we should just do things impulsively by saying, okay, let's push it to this, so that we'll know, so that we can plan with whatever time we have.
I agree.
so Dr. Rorty, what are you suggesting we do now? Should we call it a day?
No, I'm not saying we should call it a day. What I'm saying is that if we are going to use 3 hours, we should know we are using 3 hours. On days you want us to use 4 hours, we'll know we are using 4 hours. But, just in the middle of the class, and then we'll say, okay, we want to increase it by 1 hour. I think,
Okay.
it's
Yeah.
not really going to help some of us.
Well,
We
Dr.
have spent
Babawale, we are
yeah.
working with your time. So I would suggest when you think you have more time, maybe Dr. Lushola will say maybe beforehand because we really need to finish this respiratory system and get on with another system. So if you feel you have more time, you can also say, okay, next so day we're gonna do 4 or 5 hours. And whoever
Okay.
wants to adjust or plan him or herself will not do so. But that's not gonna stop us to push it to whatever time you feel you have the time for us to cover up.
Yeah.
Dr.
So
Bawale, answer my question. When are we finishing?
the when are we is that Dr. Joy?
That's my question. All I want to know is when we
Like
are finishing.
Dr. Joy, like what do you mean like when we are finishing? Like you
Oh,
mean
I
like
want to know when you're pushing it to, because you said
okay,
let's push
yes, yes.
it.
My plan is to stop at acute pharyngitis so that
Go
we just
ahead.
have one more class and we are done.
Yes, go ahead.
So let us take 10 minutes break because I myself I am mentally
Joy, yes.
So
Let's
it's
take it.
going to, Dr. Bahale, sorry. So what are you planning? So we are going to use 1 more hours more, or 1.5 hours more, or 2 hours more?
what is left we are already very familiar with them, so it should not take us more than 1 hour.
Okay.
No
you know
problem about it. Well,
Thank
thank you
you.
very much.
Go ahead.
so
Thank you.
we'll come back by in 10 minutes, so that's 8:45.
Okay. Thanks.
Hello everyone, are we back?
Yes, we are.
Okay, so um so we are moving on to histoplasmosis now, and so one so we are going to start with the risk factors, the common risk factors for histoplasmosis: immunosuppression, be from HIV/AIDS, exposure to dust from caves, or to bird or bat excreta. Usually, you find all these bird and bat excreta within these caves, and the typical location is Ohio or Mississippi. So we are going to get a history of the person um, previously visiting Ohio or Mississippi, exploring caves, or the person having a background immunosuppression, or the person is exposed to bat or the bird, excreta. So most of the time, in people that are immunocompetent, it is asymptomatic. They don't have anything, or they can just have a flu-like illness only. But people with immunosuppression, they are going to have the fulminant form. It's going to be very severe with pulmonary and or extrapulmonary manifestation. So the pulmonary manifestation is just treated like pneumonia. having non-productive cough, fever, chest pain, difficulty in breathing, and it can be accompanied with some extrapulmonary manifestation, and that's what we put in the acronym HOS from our step one. So H for the hepatomegaly, the O for the oral ulcers, the R for the rash, which is the erythema nodosum, the S for the splenomegaly, and the E is also the erythema nodosum. And in addition to this, we have to talk about bone marrow suppression. So they can cause bone marrow suppression leading to pancytopenia. So the typical presentation for the pulmonary, the fever, they have non-productive cough, chest pain, difficulty in breathing. Then extrapulmonary findings include things like hepatosplenomegaly, lymphadenopathy. So typically, the lymphadenopathy affects the lymph node of the lungs around the chest cavity. So mediastinal and hilar lymph nodes, have been affected. Then the oral ulcers, the palatal or tongue ulcers, and of course the pancytopenia for the disseminated infection. So don't forget that these are the differentials. The other systemic mycosis, coccidioidomycosis, blastomycosis, and the other granulomatous infection like sarcoidosis, all of them are differentials for histoplasmosis. So this is just like a summary of everything. So you have for disseminated disease for histoplasmosis, hepatosplenomegaly, the lymphadenopathy affecting the chest, lymph nodes, and the non-productive cough. For coccidioidomycosis and blastomycosis, they are pretty much the same thing. Both of them affect the brain, causing meningitis. Both of them affect the bone, but the bone lesion in coccidioidomycosis causes arthralgia. So desert arthralgia. While for blastomycosis, they typically have like osteomyelitis like kind of presentation. That's it, like non-healing ulcers and wound in the bone. And you see them, the skin is also affected. They have this what-like varicose ulcer that looks as if they have squamous cell carcinoma of the part. So once you see warty or varicose lesions, bone lesion, osteolytic bone lesions, meningitis, genitourinary lesions, affectation of the prostate, affectation of the testes, affectation of the epididymis, epididymitis, orchitis, prostatitis, with varicose skin lesions. Think about blastomycosis. Coccidioidomycosis will cause meningitis, bone lesion like arthralgia. They can cause skin lesions, erythema nodosum, erythema multiforme. That's coccidioidomycosis. So to make diagnosis of histoplasmosis, what should come to our mind is always the polysaccharide antigen. It has a polysaccharide capsule. So evaluate for the urine or the serum polysaccharide antigen very fast and quick. For coccidioidomycosis, you can do serology. Serology is not very sensitive and takes time. So before they can show and like, so do your PCR analysis to find out the gene. For blastomycosis, usually the culture is the best. Just do your culture and identify the broad-based budding yeast. Blasto B, that's the way we coded it there. BB, broad-based budding. Don't forget, one thing I want to mention is that we should not narrowly, we should not narrow our thoughts to, narrow board to, what's it called? Maybe I think the one we gave narrow body it was not cryptococcus.
It's
It's
crypto.
Yeah,
crypto.
yeah.
Name of
But
it.
it's not only cryptococcus that can be narrow body. So you can see histoplasmosis too. They can tell you narrow body. But most importantly, we are going to get the what's it called? The histology or the biopsy finding or the staining finding that you have the yeast within the macrophages and they are smaller than red blood cells. And these buds, which are the yeast, they have narrow body. So don't say that, why is narrow body is just talking about the diameter of the whole stuff, how it looks like. So anyone can be narrow body. So you have to look for other definitive stuff to be sure of what you're actually, dealing with. So Part of making diagnosis, you have to do your chest X-ray because they cause pneumonia. So, and what you are going to identify on the chest X-ray for histoplasmosis is presence of diffuse retinonodular reticulonodular densities. Sometimes you can see just focal infiltrates there. Depending on the chronicity, you will see cavity. So when it's becoming chronic, you are going to definitely identify cavity. So chronic infection is usually cavitary. You are going to see cavities there. So the most sensitive test is to do your urine or serum polysaccharide antigen test. That's what you are going to see mostly in the question step. And that's what you are going to pick, urine or serum polysaccharide antigen test to make the initial diagnosis of disseminated disease, to monitor therapy, and to check for relapse. So you can also do your culture where you are going to be seeing this, and you can stain, when you stain too, you are going to see this, and that is this is a macrophage, and we can see the small narrow bud yeast, within the macrophages. So what you see, this typical presentation is classic for histoplasmosis. So you can biopsy and stain any tissue. It suppresses the bone marrow, pancytopenia, so you can get bone marrow biopsy. It affects the lymph node causing lymphadenopathy. It affects the liver causing hepatomegaly. So you can even obtain a bronchoalveolar lavage, and you are going to identify this on your GIMS stain. So how do you treat? For people with mild pulmonary disease or stable nodules, they are not very symptomatic. You can treat them either supportively, or you can just give them itraconazole, anyone, till the symptoms resolve. For people with chronic cavitary lesion, you have to give itraconazole for a year. So most of the time, people with chronic cavitary lesion, they are not very symptomatic. They can just have mild cough, non-productive cough, chest pain, and that's all. They don't have the extra pulmonary manifestation. But when you do your chest X-ray, you are definitely going to see cavities. So because of that, give them itraconazole to clear the infection for at least more than 1 year. But for people with severe acute pulmonary disease or disseminated, so they're having like severe symptoms, chest pain, cough, difficulty in breathing, very bad stuff. You check your ABG, hypoxemia, respiratory distress, or it's disseminated. That's gone to the bone marrow, that's gone to the liver. You have to give them liposomal amphotericin B. So you remember, you have to put it in liposomal form so that you can protect it from other organs like the kidney, because the effect of amphotericin B, the kidneys can permeate the membrane there, leading to loss of electrolytes, particularly potassium, causing hypocalcemia. So you can give liposomal amphotericin B for 14 days for 2 weeks only. Then you now continue your maintenance with itraconazole for 1 year and more. Sometimes some people might actually need more than lifelong itraconazole, depending on the severity. So the major take home there is just to know that mild one you can treat symptomatically or give itra. Cavitary, you must definitely give itraconazole. And when it's severe or disseminated, use your amphotericin B and continue with itraconazole. That is all. So it's not really compulsory to be mastering the number of years or days. Just know the agent to give at a particular time, at a particular condition. If it's mild, if it's severe, if it's cavitary, know what to give. That's what is important. So nocardia is a partially acid-fast gram-positive branching rod that you find in soil. We know this already. It can cause cutaneous, infection. It can go to the brain and cause meningitis. At the same time, it can cause lung problem in people that are immunocompromised. So, and we said the presentation then is very similar to tuberculosis. You might not even know, until you do your staining and you identify the organism and you see that it's filamentous acid-fast gram-positive. That's where you now know it's nocardia that you are dealing with. So you give the person, is it SNAP now? SNAP is the acronym. SN.
Snap,
Yeah.
Yeah,
So
snap.
snap.
SN, trimethoprim sulfamethoxazole, for
Mhm.
nocardia, and penicillin for actinomyces.
Mhm.
So moving on to coccidioidomycosis, just remember three things: affectation of the brain, meningitis, affectation of the joints, arthralgia, affectation of the skin. And when I'm saying the joint, I mean the bone, arthralgia, skin, erythema nodosum multiforme, and the brain, meningitis. That's all you need to know. And it can cause pulmonary infection. All of them, the systemic mycosis, they cause pulmonary infection. So you can see the lymphadenopathy, the hilar lymphadenopathy, the nodular infiltrate, in the lungs. And this one particularly is native to southwestern United States, California, southern Arizona. So that's where you get coccidioidomycosis. Very common people that explore caves. True. So they can have acute pneumonia-like symptoms and extrapulmonary dissemination to where? The bone, the CNS, the skin, just like we have talked about. So it's very, very common in people that are immunosuppressed, people that are pregnant too, and people of Filipino and African descent. So they have a very high risk of having disseminated problem. We don't know the reason why, Filipino or African descent, but it's believed to be as a result of genetic influence. So it could be genetic factors that is predisposing them to having increased disseminated people with African descent and Filipino. So it's also from dust exposure during earthquakes or uh, cave exploration, just like histoplasmosis. So you get history of fever, chest pain, cough, difficulty in breathing because of affectation of the bone, arthralgia, and disseminated one, meningitis, the bone lesions, and they can have soft tissue abscess too. But the common ones, the erythema multiforme in the skin or erythema nodosum, the bone lesion, osteolytic bone lesions, and which might also present as arthralgia and meningitis. So serology is what is used. Don't forget, the eventual thing you do for coccidioidomycosis is PCR. That's the best. But serology you can do, but it's not usually sensitive because IgM increases after 2 weeks and disappears in 2 months, while the IgM appears in 1 to 3 months. So you can't be waiting. So do your PCR and get the gene and make your diagnosis straight up. So you can also, just like the other ones, you can do your bronchoalveolar liver, just like we did for histoplasmosis to obtain, like a reflection of the sputum, and you can culture that or you can stain it to identify the organism. So what you are going to see on staining, either KOH, silver stain, hematoxylin stain, is what? The spherus with endospore. You are going to see the spherus with endospore. So just picture like a big blow that has small dots inside it, the buds inside. So like I think we can check that online. I'm not sure we have it here. Yeah. So once we see the word spherus with endospore, we know definitely they are talking about so it doesn't exist in the yeast form. There's nothing like yeast form. It exists as the spherus with endospores, for coccidioidomycosis. No. This one is not clear.
It's
Very,
one that looks like pomegranate.
yeah, endospores for. Okay, yeah.
Mhm.
So you can see this now. This is it. So you can see the small. So those are the endospores, and the big container is the spheru. So that's for coccidioidomycosis. So what do you do? Acute stage, fever, cough, difficulty in breathing, chest pain, acute. What do? You give fluconazole, oral fluconazole, or itraconazole if it's mild. But if it's severe and it is disseminated, just like in histoplasmosis, you give them IV amphotericin B if it's severe and it is protracted for a long time. or if it's disseminated. Then of course you can't continue amphotericin B. You have to use your azole, either itraconazole or fluconazole, for your maintenance therapy. The same pathophysiology, the same mechanism. Just like in histoplasmosis, when it is mild too, we can give itraconazole. Same thing here. When it is severe or disseminated, we give IV amphotericin B, and we top it up with the azole later. So, but here, when it is chronic and it is cavitary, it's different. So, if it is chronic and it's cavitary and there's no symptom, you leave it, no treatment. Unlike in what's it called, histoplasmosis, where you still have to place on IV itraconazole. But here, if the cavities are expanding or it's symptomatic with the cavities, you need to go in there and do some surgical resection, then place on azole subsequently. So for chronic form of coccidioidomycosis that is asymptomatic, you don't do anything. But if it's symptomatic and it's progressive, you have to do surgery and continue with the azole. Blastomycosis too occurs in similar setting as histoplasmosis. Both of them, you find them in the Ohio River Valley and Mississippi, the same part. But it's just that aside the pulmonary stuff, this one you find it affecting the bone, the brain, the urinary tract, particularly the prostate, as well as the skin. So what are you looking out for? Aside the normal pneumonia findings, you see verrucous lesions or granulomatous nodules in the skin that looks like cancer, squamous cell cancer. Verrucous, what-like lesion. Think about blastomycosis. The bones are osteolytic. Usually, you find these lesions on your X-ray. Tell you osteolytic bone lesion. Think about blastomycosis. They are blasting the ribs. They are blasting that particular bone they are affecting. Then genitourinary involvement, prostatitic, deep-seated, pelvic pain, and other symptoms of prostatitis, orchitis, testes, epididymitis. They can all come from blastomycosis. Then, of course, meningitis and then abscess in the brain, blastomycosis. So if it's mild, you can give itraconazole. But if it's severe, you should give amphotericin B and admit to the ICU. So everything is the same thing. Severe form, amphotericin B is a go-to drug. Mild form, give itraconazole. So moving on to tuberculosis. Tuberculosis infection caused by Mycobacterium tuberculosis. We know that. The physician needs to rule out risk factors for tuberculosis, particularly history of travel. History of travel is number one that you must look out for. Has this person traveled to Sub-Saharan Africa or Southeast Asia, like Philippines, Singapore, Cambodia, and all those areas, Indonesia, Thailand, Vietnam? Watch out for all these territories. So Thailand, Vietnam, Philippines, Indonesia, Cambodia, Singapore. Anybody that is an immigrant from these areas have a tendency of developing tuberculosis, particularly within 5 years, or from Sub-Saharan Africa, or people that are homeless, incarceration, people that have been imprisoned for a long time, people that have, abnormal use of alcohol. They can be immunosuppressed too. IV drug users can be immunosuppressed. They can easily develop TB, HIV, immunosuppression. People that work in healthcare, doctors, they get exposed to tuberculosis patients. People with pre-existing lung disease or immunosuppression or advanced age, they are also risk factor. But the biggest one you must not forget, being from endemic countries, being from endemic nations, very common. And
Sorry,
of course,
Wale, do you mind just repeating the endemic countries you jotted down?
like Thailand,
Mm,
Vietnam, Philippines, Indonesia, Cambodia, and
Singapore.
Singapore. Those
All right.
Southern Asian countries. So
Okay.
most people who are infected with TB are asymptomatic. Almost everybody in Nigeria have been infected with tuberculosis, but they are asymptomatic. So that's the latent form. So the organism is just there in the lungs, subpleural area, hiding there until there is any condition that can facilitate its reactivation. So most of the time, um, they are asymptomatic, they don't have any symptom, but symptomatic patient can present as either primary or secondary, so depending. So if somebody get exposed to tuberculosis for the first time and the person has some form of background immunosuppression, the person is going to manifest with the primary form, and you are going to notice the lesions within the middle to the lower lobes. That's where we are going to see the lesions with, of course, the gum focus by the side. But if somebody already had tuberculosis infection that was confined and became latent, and the person had, a form of immunosuppression, either cancer, malnutrition, or the person start using some medication like TNF alpha inhibitors, etanercept, infliximab, or the person develop some exposure to silicosis, they can have reactivation of latent tuberculosis, and you are going to see the lesions within the upper lobe of the lungs, cavities within the upper lobe. For secondary, upper lobe affectation. For primary, middle, and lower lobe. So most of the cases, they are confined to the lungs. That's the commonest site of affectation. So you just see cough, hemoptysis, drenching night sweat, fever, weight loss, and all those features. So sometimes it can disseminate hematogenously, particularly miliary TB, and go to any other organ, can go to the spine, Port disease, can go to the adrenals, adrenal insufficiency, can go to the spleen, can go to the brain, can go to any part of the body, the joints, So management of so the summary of this long statement here is that if you want to test an individual that has tuberculosis and you have given that person BCG vaccine, it's better you do your interferon gamma release assay because you are not going to generate a false positive result. So somebody that are taking BCG vaccine, if you try to do your Mantle tuberculosis skin test, you can get a false positive result because the person is already sensitized without being infected, but the person has been sensitized. But even if somebody has BCG vaccination and the person doesn't have tuberculosis proper, if you do your interferon gamma assay, it's not going to pick it as positive. You're not going to get any false positive one. So the best test to do for people with BCG vaccine is what? Interferon gamma release assay. So latent disease, people with maybe people that have been exposed but are not symptomatic. So you can make your diagnosis of latent disease by doing your Mantoux tuberculosis skin test or doing your interferon gamma release assay. But the one we are talking about here is the tuberculosis skin test. So these are the two tests you can use to make your diagnosis of your latent disease. You diagnose by doing your tuberculosis skin test or your interferon gamma release assay. Both of them will be positive, but the patient is not going to be symptomatic. Yeah, so the person has had a previous exposure, asymptomatic, but the bacterial is there. How do you know? Do your interferon gamma release assay or your tuberculosis skin test. Both of them is going to be positive. Yeah. But if somebody has received BCG vaccine and you want to test for latent, so it's best you just go for interferon gamma release assay because this can give you a false positive value. So moving on to the tuberculosis skin test, we need to know what to consider as a positive test depending on the situation of the patient. So any patient that has a very high risk of developing tuberculosis, that is, any patient with HIV risk factor immunosuppression, any patient that has been in close contact with anybody with tuberculosis, or any patient that you did the chest x-ray, you saw evidence of tuberculosis. If you do your positive, if you do your skin test, which is your tuberculosis skin test, you don't need the reaction to be too wide before you can say it is positive. What am I trying to say? You inoculate the antigen into the body, the antibodies in that person is going to I mean, not the antibody, the T cells, because this is type 4 hypersensitivity reaction. The T cells are going to respond to the antigen, and there's going to be inflammation, and there's going to be induration. Now you try to measure the diameter of that induration. If it's within 5 to 9, this is okay for people with this condition. People with HIV, close contact, and evidence of TB on chest X-ray. The standard one should be more or equal to 15. In healthy people, it should be more or equal to 15. But in people with HIV, close contact with TB patient, evidence of TB on X-ray, immunosuppression from any cause, transplantation, it's between 5 to 9. That's a positive result. Once it is more than 5, that's the word. We don't even need to be saying 5 to 9. Once it is more than 5, that is positive for people with these factors. But people with CRIP, so chronic, the C for the chronic, the R for the resident, that is immigrants from endemic countries. So immigrant from Cambodia, immigrant from Nigeria, immigrant from Indonesia, all those areas, Vietnam, within 5 years. That's R. I for IV drug abusers, people that use IV drugs. P for people that live in clusters, homeless, nursing homes, correctional facilities. This category of people, your threshold is between 10 to 14. Once it is more than 10, not 5. Once it is more than 10, this is for this category of people. The CRIP, chronic disease, resident, which are immigrants, IV drug abusers, people that live in clusters, CRIP. Now, the last one is now for the healthy people. Once it's more than 15, then you can say they are positive for the TST test. Okay. Now,
Sorry, Doctor. Saying that greater than 15 is healthy.
yes,
Okay.
greater than or equal to 15. Once you get 15 on dot or more, it's positive for them.
That's what I wanted. I heard healthy. That's what I was asking.
Yeah. So,
Okay.
immunosuppressed people with latent infection may have a negative TST test. Yeah. So this is energy because the T cells, they are weakened. They cannot mount any inflammatory response to that antigen you have inoculated. So TST will be falsely negative in them. That's what you call energy because of how they are immunosuppressed. So all patients, so this is where the question comes. This is where the question comes. So any patient that you have discovered that the patient is asymptomatic and the person has a positive TST test, the next thing to do is your chest X-ray. That is the next thing to do. You want to check if that person has rule out active disease. So you have to do a chest X-ray to rule out active disease once you notice that the person has a positive PPD. Very, very important. So that means that even if the person is not coughing, but your patient has a positive PPD test, you did your X-ray, you're able to see features of tuberculosis, you have to treat. You have to treat. You consider that active disease and you treat. You treat. So what do? You obtain mycobacterial culture of sputum. So that is the most accurate test to do. You have to obtain the culture, from the sputum. But because of the fact that it takes like 2-3 weeks, you can just do your sputum acid fast staining. You collect 3 samples 8 hours apart. You do your acid fast staining, you identify the organism, then you commence your treatment. So if your stain is positive, you have to do your PCR or your NAT with the culture, definitely. You still have to culture, but you will not wait for culture results before you start your treatment. So NAT is GeneXpert. Your GeneXpert will help you with your diagnosis. At the same time, you can also assess for sensitivity to rifampicin. And your culture too, you identify the organism. So you commence your treatment immediately. So if extrapulmonary TB is suspected, you have to take from the site. If it's a bone, take from the bone. The intestine, take from the intestine, any part. So this is you can see the Zinesi stain, the blue background, and you can see the red red, organisms, acid fast. So, people with secondary disease, we said they have cavitary infiltrate in the upper lobe of the X-ray. Very, very important. So this is very common in people with the secondary infection, just like we have here, upper lobe cavitary infection. We can see millets. We can see like tiny, tiny, small nodules here. So this is talking about someone that has the disseminated form with hematogenous spread to the other part of the body. So once you see this, you can be rest assured that that TB has gone beyond the lungs, and the person is dealing with the miliary tuberculosis. So this occurs in the disseminated form of tuberculosis. People with HIV or people with any primary tuberculosis can have lower lobe infiltrate. We have talked about this, with or without cavitation. So let's say somebody has HIV and that's the first time the person is encountering tuberculosis. Definitely, the person is going to have lower lobe infiltrate. So the multiple fine nodular densities throughout the lungs are typical for miliary tuberculosis. So all cases, both latent and active, must be reported to the local and state health department. So watch out for this in the question stem. They can tilt you to making diagnosis of latent infection. So you do your TST test, it's positive. Definitely you have to report. You have to report. Despite the fact that it's not active, you have to report to the local and state health department. Anybody that is suspected to have active tuberculosis, the person has to be isolated in a negative pressure room. Negative pressure room that sucks air inside but does not allow air to go outside. So there's no way the droplet the person is releasing will be able to get outside. That's why you call it a negative pressure room. And if you are going to be entering that room, you have to wear a N95 mask. That mask tightly fits the mouth, the nose, and it filters 95% of the air that is moving into the nose. So it doesn't allow inhalation of the droplets. So, okay. So, how do you treat latent disease? What do you do? The rule is 346, 346, 346, 346. So once you have confirmed latent disease, what you do is that you just follow the 346 rule. So you can either combine rifampin with isoniazid for 3 months, or you give rifampin only for 4 months, or you give isoniazid only for 6 months. So the one that is longest is isoniazid. So most of the time in the question is isoniazid that they usually put here. So just know that latent disease, not active. You have done your PPD test, it is positive, the person is asymptomatic, no sign of active disease. You do your chest X-ray, it is negative. So you still have to treat them. 346 rule. Combine 3 months, only one, which is isoniazid for 6 months, only rifampin for 4 months. Anyone for active disease, symptomatic, PPD is positive, symptomatic, PPD is positive, X-ray finding of TB, you have to treat them as active disease, and you have to give them DOCT, which is a directly observed multi-drug therapy, using your 4 drugs for the first 2 months, your isoniazid, pyrazinamide, rifampin, and ethambutol for 2 months. That's your RIPE regimen. Rifampicin, isoniazid, pyrazinamide, ethambutol for 2 months. Then you use only isoniazid and rifampin for 4 months. So the code is, just know that when you are using less number of antibiotics or anti-tubercular drugs, you are going to be having longer months. When you are using more of them, you are going to be using them for shorter months. So that's the way to code it. But maintenance is usually longer than induction. So starting is short, you use all 4 of them. Maintenance is long, you use only 2. So how you felt about the TB medications, you need to know their side effects. Ethambutol can cause optical neuritis. Watch out for that eye problem. Isoniazid has lots of problems. It can affect the liver, but the commonest cause of liver problem that is most severe is pyrazinamide. Pyrazinamide hepatotoxicity potential is more than isoniazid. Isoniazid can affect the nerves, causing peripheral neuropathy. So you have to administer vitamin B6 for that. Isoniazid can cause lupus-like syndrome, drug-induced lupus, positivity of anti-histone antibody. It can also cause sideroblastic anemia, Sideroblastic anemia, which you are going to be sideroblasts, because it causes absence of what? Vitamin B6, right? And you don't have the cofactor to catalyze conversion of succinyl CoA plus glycine to ALA, and there's nothing to form the heme. So this is going to be having sideroblastic anemia. Sideroblastic anemia with high accumulation of iron, because the iron is not going to be combined with porphyrin to form heme. There's no porphyrin being formed. So watch out for that. Hematology section, Dr. Varinde is going to talk more about that. CYP inhibitor, it inhibits CYP. So you want to be careful with medications you combine with isoniazid, because isoniazid is going to render them toxic because of CYP inhibition. Pyrazinamide, liver. Just remember liver and gout. Hyperuricemia, gout, and liver. That is pyrazinamide. Liver, the most dangerous to the liver, pyrazinamide, can cause hyperuricemia. Rifampin turns the body fluid orange. It's an enzyme inducer. CYP inducer turns the body orange. Moving on to the non-tuberculous mycobacteria, the one of concern here is
Sorry,
mycobacterium.
sorry, Dr. Babole. So for the latent disease, I think at the timing you said rifampicin alone is 4 months, right? From what they're saying.
Yes.
Now, or you can combine it with isoniazid
Yes, for
for
3
3
months.
months, or isoniazid alone for 6 months.
Yes.
Okay.
So Dr. Kene has forgotten that we have class. Most likely, that's why she's dropping question. Okay. Maybe someone can remind Dr. Kene that there's a class. Maybe she can join. So, Mycobacterium avium complex. This infection is very common in people with background immunosuppression or people with existing lung disease. So we have to look out for that. There is lung disease somewhere, and there's background immunosuppression before you can see avium complex. So they can have maybe a background COPD, CF, or even tuberculosis proper for Mycobacterium tuberculosis. Any of those three. Or there is something that's causing immunosuppression, like HIV. And before you can start having problem with this infection, the CD4 count usually goes less than 50. So it's one of those age-defining illness. So Mycobacterium cancer can also cause similar problem, but the one we are focusing on today is a Mycobacterium avium complex. We have other ones, the non-tuberculous one, which includes Mycobacterium marinum, which can cause hand infection. People that operate with water bodies. Abscesses can form abscess. Mycobacterium ulcerans, that's what is implicated in Buruli ulcers, chronic ulcers that are non-healing. All of them, that's what they do. So hand infection, abscess, Buruli ulcers, even the chronic. So they cause chronic non-healing wounds. So just like I've said, Mycobacterium avium commonly affect people with background immunosuppression or existing cavitary lung disease or any other chronic lung disease like cystic fibrosis, COPD, tuberculosis. Just think of anyone. But there's a primary pulmonary disease that avium complex is implicated in without the person having any background immunosuppression or having any chronic lung disease. The person doesn't have any chronic lung disease, any cavitary lung infection, but they can develop avium complex infection. So that's the primary form, and it is confined to the lungs alone. So you call that the Lady Windermere syndrome. So this is being postulated to occur due to the fact that we have some individuals that are not smokers, but they have difficulty expectorating. So that's why it's common in people that are elderly. When they have difficulty expectorating coffee, so you tend to have mucus settling within the dependent area of the body. There are some areas of the lung that the bronchial is situated downwards when they lie supine. So it's very difficult to move mucus against gravity in that area, and that's the right middle lobe and the lingula of the lungs. So the lingula and the right middle lobe of the lungs, um, you know, readily accumulate mucus in people that have difficulty expectorating. So this category of people can easily have this Mycobacterium avium complex infection, affecting them and causing the disease. So the secondary one is the one that happens in people with COPD, tuberculosis, and cystic fibrosis. So it can cause disseminated infection in people with AIDS, particularly when it is less than 50 and they are not on head. Now, what are these features we are even talking about? Sometimes they can just have normal TB presentation, fever, cough, weight loss. But with time, it can get disseminated. And that's what you typically see in the question, disseminated from. That's what you are going to see. You just see that somebody's having something that looks like TB, fever, cough, weight loss, drenching night sweat, and suddenly you see involvement of the GI. Please open your mind to Mycobacterium avium, involvement of the GI, affectation of the intestine majorly. They have diarrhea. Non-bloody diarrhea. Please take note. Non-bloody, watery diarrhea. Affect the liver, hepatosplenomegaly. In some people, they might not have all this. They can just have focal lymphadenopathy only. That is it. So it's very common in people who have their CD4 count less than 50 and they are not on heads. It's a problem in them. Don't forget the presentation. Normal lung presentation, GI manifestation like diarrhea, abdominal pain, and hepatosplenomegaly. Very important. So sometimes it can affect the adrenals, leading to adrenal insufficiency. We know that tuberculosis is the commonest cause of adrenal insufficiency in low resource setting. Why the commonest cause of adrenal insufficiency in advanced countries is what? Anybody? Autoimmune adrenalitis. So how do you make your diagnosis? You have to obtain mycobacterial culture. Yeah. Just like tuberculosis, that's definitive. Obtain your mycobacterial blood culture. The lab value is going to review anemia. It's chronic infection. Hypoalbuminemia is a chronic infection. Hypoalbuminemia, because albumin is a negative phase reactant. So it means that from our pathology, it means that albumin is going to sacrifice itself. It's going to release all its amino acids so that you can be using that to be forming all the positive phase reactants, procalcitonin, serum amyloid A, and the other ones, instead of albumin. So albumin will keep dropping, keep dropping. And because of the fact that typically affect the liver, you can have elevation of LDH and alkaline phosphatase. So you can biopsy any of the tissue. We said it affects the liver, it affects the intestine, bone marrow. So you can biopsy any of them. You are going to see foaming macrophages with acid-fast bacilli. Whatever the test they did, you will definitely end up with, the acid-fast bacilli, or they will tell you, they might not really tell you the growth in the culture, but they can tell you that the stuff is acid-fast, positive. So you don't see granulomas in people that are immunosuppressed. That is normal, constant feature. How do you treat? Very important to know the treatment. Very, very important to know the treatment. So what you usually do is that you combine a macrolide with ethambutol. That's what you do. So, and the preferred one is clarithromycin because that one facilitates clearance fast than azithromycin. So you combine clarithromycin with ethambutol. That's the first line. Please, this is not a candidate that you are going to be giving right. Right is not going to work here. So you give macrolide with ethambutol. And preferably you want to choose azithromycin. But there are some conditions where you need to add a third or a fourth agent, particularly like rifampicin. You might need to add rifampicin, particularly in people that have CD4 count less than 50, number one. Somebody that has no response to heart. Because ideally, even before you start your treatment, ideally what you're supposed to do first is that if the person is naive, that is, the person has not started heart before, start the heart. Start the heart, then you can now, do your normal antibiotic treatment. Starting heart is very, very important. But sometimes after you started your heart, it might not work. Yeah, because either it's due to the fact that the patient is not responding to the heart and the CD4 count is not coming up, or the person has a very high mycobacterial load, or the CD4 count is just too low, it's less than 50, or what else do I have here? Setting of resistance. So you can use your clarithromycin, ethambutol, and rifabutin in that condition. So you continue there for 12 months until your CD4 count is more than 100 for at least 6 months. So don't worry yourself about this algorithm. Nobody is going to ask you that, but just know the drug of choice. You start your anti-tubercular agent. If this individual is drug naive, you commence your antibiotics, macrolide with ethambutol. And if the CD4 count is less than 50, you have to add a third agent. If the person is not responsive to the heart, you have to add a third agent. If the mycobacterial load is just too high, you have to add a third agent. So
Please,
now,
can you come again, please, Dr. Babawala, can you come again?
so I said,
Okay.
if the CD4 count is less than 50, you have to add a third agent. This is it. I think I have it here. So
If it is greater or less than, which of them?
if it's less than 50,
Is it not supposed to be less than 50 for us to even diagnose the patient with MAC?
Yeah, so sometimes it might not be less than 50 and they will have it. Sometimes.
Okay.
But
Okay.
most commonly, when they are less than 50, they would have it. Most commonly. But sometimes it's not an absolute rule. So, yeah.
No, why I'm asking, why that question is coming is because you said if that is less than 50. That's why I was asking, because I know that, yeah.
I get you. So, that's just one of the indications. But most of the time, before you even have this condition, it will be definitely less than 50. But, this is just the conditions. So, if you do your CD4 count and it's less than 50, add your rifabutin to it. So, but if it's not, you might exempt it. If there's resistance to any of the medication, you can use it and add butane. What else again? Poor response to ART. Use it. So, and high mycobacterial load. So you are just doing this to just limit resistance to any of this medication. Sorry, I was wrong what I said. You can't use it when there's resistance. You are doing that to limit resistance to the medications. So
It's a poor response to high viral load.
Yes, high viral load, high mycobacterial load, not viral. High mycobacterial load, poor response to heart, CD4 count less than 50, resistance, prevents resistance. All these things it's just for us to know. They are not the major thing. The major thing is to know the clarithromycin and the ethambutol. That's it. So that one is just side stuff. So routine MAC prophylaxis is no longer recommended in HIV. So anybody that has HIV and the CD4 count is 50, yes, but the person is on heart, don't give azithromycin. But if the person is not on heart, they must receive azithromycin for MAC. So before, it used to be absolute. You are on heart, you are not on heart. Once it is less than 50, give chemo prophylaxis for MAC. But now, it doesn't change. If the person is on heart, don't give. If the person is not on heart, give it. So, moving on to pneumocystic giroveshi.
Sorry, so in summary, Dr. Babawala, so MAC causes mainly of it can cause cavitary lesions in the lungs, but mainly is extrapulmonary infections.
Yeah.
Okay,
it can cause extrapulmonary in addition to the pulmonary.
Okay.
Yes. So that's it. Most of the time, if the question wants to come, so that you'll be able to identify it easily, they are going to add the extrapulmonary. So watch out for the diarrhea, watch out for the liver problems. PCP I think we stop at PCP. I think we stop at PCP. Yeah, so PCP usually occurs in people with background immunosuppression, age, cellular immunity. So it causes, symptoms and signs of atypical pneumonia. So distal exertion, fever, non-productive cough, of course, severe hypoxemia. It can be that bad. Severe hypoxemia, and if they are on immunosuppressive therapy, glucocorticoid, you can easily tilt towards acute respiratory failure. Most of the time, you might not be able to nail it down from the presentation. So, but the fact that it's non-progressive can just give you an idea that, okay, this is not typical. This is atypical. So, how do you make the diagnosis? You are going to do cytology of the induced sputum. You are looking at the cells there, and you stain it with silver stain and immunofluorescence. So once you do your induced sputum, or you collect the sputum from bronchoscopy, maybe lavage or washout, you do your silver staining of that, and you are going to see disc-like shape of the cyst. So the cyst, you have this disc-like shape. And one thing you must also know about PCP is that you have to check the ABG. Well, they might not really ask us that, like, what's the best next step, ABG? No, but they are going to give us the value of the PaO2 because it's of high importance to the management and the severity. So we check the PaO2, we calculate the A gradient from there. It's very important. So don't forget the silver staining, or you are going to see this shape. And when you do your X-ray, you are going to see the diffuse granular opacity, which is spreading out from the central area. So butterfly-like granular interstitial bilaterally symmetrical opacity, which is confined to like the middle or the upper lobes. Unlike COVID, that is basal, and peripheral. But this one is central, middle, upper lobe, bilaterally symmetrical interstitial infiltrate. That's what you are going to see. So usually the CD4 count is less than 200. Anybody that typically develops, most of the time their CD4 count is less than 200. So once you see a patient CD4 count is less than 200, you want to quickly give prophylaxis for PCP. So the other test that you can do, or what you are going to see in the question stem, is presence of the beta D glucan. So just like in somebody with invasive aspergillosis having this, but PCP also have this. So LDH due to lung destruction is also increased. So what do? You want to give them high dose Septrin for 21 days. So if it's moderate to severe, mild to moderate, you want to give it oral. If it's severe, you want to give it IV. So pay attention to that. If it's mild to moderate, you give it oral. If it's severe, you give it IV. Mild to moderate, oral, severe, IV. So what are you even combining? It is Septrin. But in some situation, you can use other medication. So Septrin is sulfur containing. You can substitute it with another sulfur drug, that is Dapsone. So you can use trimethoprim Septrin, trimethoprim Dapsone. Or you can use PC. PC is very important because you can use it both in moderate or mild and severe condition. So you can use trimethoprim sulfamethoxazole in all mild, moderate, severe. You can use primaquine, clindamycin in all mild, moderate, severe. You can't use atovaquone in severe. So in severe, you can either use pentamidine or you use primaquine, clindamycin. So how do you even grade it? Mild, moderate, severe. So what you just do is just that mild and moderate, same category, severe, separate category. So for you to say it's mild or moderate, the alveolar gradient has to be less than 35, and the PaO2 has to be more than 70. Once the PaO2 is less than 70 and alveolar gradient is AA gradient is more than 35 or equal to 35, that is a severe condition. So you give high dose trimethoprim IV or you give pentamidine IV, or you give primaquine clindamycin IV, and you are going to add a prednisolone taper to it within 3 days or 72 hours of commencing that antibiotic, because if you don't do that, there's going to be massive pulmonary inflammatory response to the organism that is being killed by the antibiotics you are giving, which can worsen the hypoxemia. So what you do is that once you are treating the severe and you are giving high dose Septrin IV, to limit the inflammatory response to the organism being killed, you have to give prednisolone. Very, very important. So you are going to see the option Septrin only. You are going to see the option Septrin plus prednisolone. So if you pick Septrin only, you might be wrong. So in same
Sorry,
patient,
sorry,
yes,
Dr. Baba. Do you want to just take that part again? It became really confusing on the end part, especially when the addition of the prednisolone.
So do you understand the grading?
Yes,
PO2,
I do understand the grading. Thank
yeah.
you.
So what I'm trying to say is that once the PO2 is less than 70 and the A gradient is more than 35, that is severe. So now you are going to give IV of any drug, IV Septrin, IV primaquine, clindamycin. Now, that drug is going to cause massive destruction or killing of the PCP, and there's going to be a resulting inflammatory response in the lung to that dead organisms. And that can also, that inflammatory response can also cause insult to healthy tissues. So that's going to damage the other healthy tissues and it's going to worsen the hypoxemia. Now, to prevent that from happening, you want to limit the inflammatory response to the antibiotic, to the PCP being killed by your IV drug, by your IV Septrin. You are going to administer prednisolone within 72 hours of commencing that IV Septrin.
Makes sense. Thank you so much. Thank you.
So that is how you can reduce mortality there. So do we have any question before we call it a day? Any question? Okay,